جدا
اهلا دكتور
على
نجيب، يا
عزيمة،
مرحبا.
وإن شاء الله يا رب بالنجاح إن شاء الله.
يا مرحبا. يا اهلا دكتور نجيب، يا مرحبا.
Hello, Dr. Mohammed.
Yes, good evening. Are you ready?
We're still waiting for Dr. Ali to join.
All right. Let me know when we would like to start.
Hi, Dr. Luay, you hear me?
Yes, Dr. Osama, you are most welcome.
Yeah, thank you.
Dr. Muhammad, Dr. Ali has difficulty joining in, but you can start the introduction and welcome message.
Yeah, we can wait for him. It's not a big deal. Just give me the... Can we start, Joseph?
Yes, doctor. Like I said, Dr. Suwaidi have difficulties, but you can start the welcome message and introduction.
Yeah, you can put my image there.
I
Okay,
just
doctor.
try to do share the screen, just to do a test. Is it okay? You can see it?
We can see it, doctor. Yes.
Okay, fine. I will stop sharing. Okay.
Okay, Joseph, are we live now?
We are live now, doctor.
Okay, good. We can start. So let's start, please. Let's be live for all the audience attending the conference through the webinar or through the other channels which is available at this time. So dear colleagues and friends, I'm very delighted and pleased to be with a very eminent orthopedic surgeon around the UAE today to present for you the third version of the Frontiers in Orthopedic Congress and seminars. Today we will have a few topics from the oceans of orthopedics, and that will be presented by very eminent speakers. We will talk mainly about the few topics about upper limbs, lower limbs, and pediatric. The speakers will have 15 minutes each to present his talk, and we will have 5 minutes for question and answer. Every speaker will be joined by 3 eminent expert speakers to lead the session and to be actively participating in asking questions and answer from the audience, or they can also ask questions themselves because they are mainly expert in that field. At this time, I will take the opportunity to thank the MCO for her efforts and time to arrange such a beautiful webinar. And at the same time, I would like to thank the supporting companies and sponsors for their help in making these things happen. The big thanks for all my friends, speakers who accept my invitation, and they are participating all the time actively in most of the activities, especially scientific activities in Abu Dhabi and other Emirates, and also in the orthopedic, in the Emirate Orthopedic Society. At the same time, we would like to thank all the dear colleagues in their homes behind the screens or behind the phones watching us. Hopefully that you will have interesting topics, interesting evening. And I really encourage you to ask questions and actively participate with us. At the end of the day, we are here to share our experience and to learn from each other. Every question is an important, every suggestion is a valid suggestion. The topics today, we will start with the upper limb, and the first topics will be presented by Dr. Ali Al-Suwaidi, and he will talk about the management of fracture dislocation in the middle group age. Dr. Ali Al-Suwaidi is a consultant orthopedic surgeon. He's a well-known surgeon in Abu Dhabi and in all Emirates, and he's also very famous around the world. He's the president of the Emirate Orthopedic Society. He's also president of many other society, and other to the his daily work in the shoulder and upper limb units in Burjil. He's the manager of the units of the shoulder and upper limb and sport in Burjil. In addition to that, he's a very close friend. We spent many years as friends, partners working together, and I have really learned from him a lot, not only in orthopedic and also in the management and in life. I would like to welcome Dr. Ali Al-Suwaidi and this screen for you. You are most welcome, and thank you very much for accepting the invitation. I know that you are at this time busy and you have very short time, but you are always there when we need you. Thank you very much, Dr. Ali Al-Suwaidi.
Thanks, Luai. Thank you. I'd like to share the screen now. If you allow me to share screen, can we just hold on? Okay, sorry. Albert, are you there? This will stop on this. Are you able to see the screen or?
No, doctor, please click on share screen. But before you click on share screen, doctor, make sure your PowerPoint is open.
So during this time, while you are sharing the screen, I would like also to welcome our expert panel, Dr. Stefan, Dr. Najib, and Dr. Amin, to be our expert panel in this session.
Welcome.
So they can lead the session, ask questions, and answer some questions if they allow us.
Okay. Is it possible now? Do you
Yes,
see
doctor,
that?
please click on share screen.
Okay. Is that seen? Is it okay now?
We cannot see, doctor. Just make sure you have clicked on share
You cannot
screen.
see it?
No, doctor.
All right. You can see it?
Yeah, it's about to display, doctor.
You just
Okay.
started, yes, Dr. Ali, you started your screen.
Okay.
So click on full screen mode, doctor.
Click on the screen.
Full screen mode, doctor.
Sorry.
Click on the full screen mode.
Where is it? All screen. Where not sure.
The down button. So then to the very low part of the screen on the right side, so the screen will be full.
all right.
At the very lower part, Dr. Ali, very lower part of the screen, you will have the increased size and lower size, very lower part of the your screen down, your screen of the computer.
Okay, all right, okay, maybe.
Not this one, not the other one. Yes, this one. Thank you.
Yeah. Okay.
That's it. Thank you very much.
All right, okay, sorry, just to, okay, is that obvious now?
Yeah, it's very obvious. Yes,
all right,
please.
okay, I'm sorry, guys, for the glitch on the sharing the screen here. So the topic that it was assigned to me is kind of a dilemma and a difficult topic to address, to be honest. But Dr. Luai and myself often faced with this type of fracture, which is not an easy one to there is no cookbook for us to follow. So we have to do it kind of as it comes, and then we have to use all our expertise and knowledge over the years to try to deal with a situation like this. So I'll let you know why it remains a dilemma for us and difficult one. So let me trying to move the screen now. I think it's not moving.
Yeah, it's moving.
Okay.
It's moving.
Okay, it's moving a little bit, but this is jump to classification. So just hold on. It's just lagging a little bit. I'm sorry about that. Sorry. Let me see. So the objectives, we'll talk, Jerry, just briefly on the classification. I mean, I'm not going to talk about the classification of proximal humeral fracture. A lot of people knows about it. And the talk today is going to be focused mainly on the complex fracture, mainly the fracture dislocation. And how we're going to do it? Is it the management, and is it hemiarthroplasty? Is it over-reduction tendon fixation? We look at the literature review, which is actually scarce. There isn't a lot of literature review on this age group, and the age group that I am going to talk about is between 50 to 65. I'm going to talk about my indication for hemi and this type of fracture in this age group, technique to optimize the outcome and take home message. So those are the classification. Everybody knows the NEAR classification and the AO classification, and the fourth, 3 and 4, basically when there are 3 displaced fracture, and what makes it worse for the fourth part fracture, sometimes the added dislocation. So the fracture dislocation and head splitting are considered to be a poor prognostic signs for head viability. Sorry, we'll have to go first. So this is the AO classification, and basically we are talking about the C1, C2, C3, and sometimes the B3. Those are the type of difficult classification that we have to deal with. So this is the dilemma we're talking about. I'm talking about age group 50 to 65. Often there is osteoporosis, particularly in female. There is an associated cuff pathology. You might have rotator cuff disease in this age group. The referred shoulder arthroplasty has become more and more in trend for, I would say, older age group, not this age group. This age group is considered still in the world literature considered too young for referred shoulder. So there is a lack of randomized controlled studies and good evidence for the best management of for this age group. And this is what I found when I was researching for a good studies to look at this particular age group. So the thing is, there aren't a lot of good studies for this type of for this age group. Let me see if sorry about that. Just
Next is fine. If you press next, it's okay.
yeah, it is.
Or the space button.
Yeah, that's what we are trying to do that. So the management, is it gonna be as we talked, a hemi versus open reduction tendon fixation? Those are both viable options, but we cannot. It has to be selective, and we have to find which one would be the right one for us. So about the open reduction, fixation, which is very familiar to a lot of us here in dealing with the proximal humerus fracture. As I said, familiar technique to preserve anatomy. It's cost effective. It's much cheaper than hemi or reverse, and has a lower revision case in most of the cases. But once again, there are higher complications, particularly in osteoporotic patient where you have screw penetration, where you have loss of reduction in a weak bone, and when there is comminution, there is a problem with this type of osteosynthesis. The vascular necrosis are particularly with the type of anatomical neck fracture and dislocation, and this one, the four-part fracture dislocation, I mean, there is a high rate of vascular necrosis, and could be a technically demanding to fix a four-part when it's particularly dislocation or a significant displacement or even a head splitting. So what about a prosthesis? Now, prosthesis, there are patient-specific age. Osteoporosis female seem to be lend itself more towards the prosthesis than osteosynthesis, because with a lot of female in this age group, often you have a weak bones. And when it comes to the fracture, the four-part fracture dislocation does kind of push you towards thinking of prosthesis. The humeral head bone stock, the articular surface fracture, the number of fracture and fragments and comminution often will make you wonder, would osteosynthesis versus prosthesis would be the right way to go? And those are things you need to be thinking about. When it comes to hemi, I mean, it's the hemi arthroplasty, the benefit of it as compared to reverse, for example, it brings it back to anatomy, gives you back the anatomy, the normal anatomy, and does cost much less than reverse. But today we're not talking about reverse for this age group, but I'm putting it there as a comparison. Now, against against are you seeing the screen?
No,
Sorry.
we are seeing Dr. Usama's screen. He's sharing his screen. Dr. Usama, would you please just stop sharing your screen? Yeah. Yes, we get back to the Dr. Ali's screen.
Sorry, are you seeing my screen now?
You can share screen again, doctor.
You have to share screen again.
Okay. I don't know. Sorry.
Yes.
Is it?
Yes, it's okay.
But again, we need to go. Where are we here now? It's in. Okay. So again, as I said, for hemi, the problem with hemi arthroplasty for those type of fractures, the hemi, the outcome, it depends heavily on tuberosity healing and rely on good rotator cuff function, and it's very technically demanding type of procedure as compared to reverse shoulder arthroplasty. Now, the first one who advocated this type of procedure, Neer, back in 1970, when he talked about the use of prosthesis for four-part fracture as compared to open reduction and internal fixation. And this is the one who popularized it. Now, this is a retrospective study looking at randomized control, looking at fracture dislocation in 29 patients. Unfortunately, this is a younger age group, and the mean age is 35 years, which is all younger than the one we're talking about, and all have concluded this study that the 3 and 4-part fracture could be with osteosynthesis, could be treated with osteosynthesis. As I said, there are not many studies in the literature to talk specifically about the middle age group, the one I'm talking about. Another one here, hemi arthroplasty that advocate the hemiarthroplasty for humeral four-part fracture in patients 65 and years. But they were comparing those. This is a randomized controlled trial, but they were comparing either non-operative treatment versus hemiarthroplasty, and they did not find a clear benefit in treating patients 65 and older with four-part fracture, either with hemi or non-operative. Again, this is another study. This is from England. This is a larger government-sponsored type of study that was published in JAMA in 2015, and they are talking again on an older age group, and they had a mixed bag of about 250 patients with different, not a complex, but all proximal humerus fracture. And they talked about whether non-surgical ORIF or head replacement will be the right thing for those patients, and actually did not see any significant difference. This study, particularly in England, has sent wave shock to a lot of surgeons because it shows that even the insurance held back approvals because with this study showing no benefit. So it has affected awareness, and even insurance company difficulty to get approval when this study has came out. So in my practice, let me talk about just my practice. This place, 3 and 4-part fracture. I will go with ORIF, dislocated 4-part fracture, including anatomical neck fracture. I will choose a hemiarthroplasty with fracture-specific humeral stem. And ideally, I will use what we call platform system that some of the companies has that can convert the hemi to reverse shoulder arthroplasty if needed afterwards. Now, the 3 and 4-part head splitting fracture depends on the size of the head splitting reducibility, the fragment, and that can go either way. If you are able to fix that head splitting, and it's not dislocation, I'm not talking about dislocation with head splitting, I'm talking about 4-part head splitting per se, and you can put some screws, headless screws fixation, and you can put an osteosynthesis. That's even possible, but I always say keep a prosthesis on the table just in case you might need it. So this is actually from Emily Chong that presented this in a technique in hemiarthroplasty for proximal humeral fracture that was published in 2016 in the shoulder and elbow surgery. And that shows you the importance of taking every technique, every aspect of this technique. So basically you have to have sutures, high tensile sutures around the GT and around the lesser tubercle, and then pass it along the stem. Now, in the stem itself, she put bone graft, so that will allow healing of the tuberosity. Now, as we talk, the most important aspect of hemiarthroplasty is the healing of the tuberosity. So, and this is important for us. So you need to have suture that goes all around the prosthesis, around the stem, and involving the two tuberosities. Pass it along and pass it in a horizontal and a vertical fashion to prevent the migration, the superior migration or the horizontal migration. And this is just to show you some of those aspects of this technique. So as she showed in this technique, she put a bone graft within the stem, and this is a stem that's specific for the type of fracture, the 4-part fractures, or for the fracture that you've used. But again, as I said, the most important thing is the fixation of the tuberosity. This is the most important aspect of this type of procedure, and the most highly demanding step. So this is just a case that we did, Dr. Loy and myself, recently, a 55 years old pilot. Again, this is a 4-part fracture, And this is just the way it's three-part. This is the 3D reconstruction of the fracture, and this is the final result. Again, because of the comminution, you might not be able to have a big GT, but this is the final construct, and hopefully the patient. This was done about 2 months ago, and he's still in an arm sling, and we started physiotherapy recently. So the take-home message here: the fracture dislocation, proximal humerus fracture are rare. It actually accounts to about 3% of all proximal humerus fractures. So it is rare, but requires high skills and expertise to achieve a good outcome. Now, non-surgical treatment in this young, I consider still young group, not indicated if the patient is fit for surgery. So the choice between osteosynthesis and hemiarthroplasty remains the decision in the hand of the surgeon, that this surgeon should be an expert surgeon, skilled in both, to be honest, when he's dealing with those type of complex fractures. Now, surgical intervention often associated with high complication rate and revision surgery often needed. Now, what I would recommend is the use of the new platform implants that can allow easy revision surgery from hemi to refer shoulder arthroplasty if the tuberosity failed to unite or resolve. Thank you, and sorry for the technical problem that we faced today. Thanks, Dr. Loy. Thanks.
Thank you very much, Dr. Ali. We have the expert panel, Dr. Stefan, Dr. Najib, please, if you want, and Dr. Amin, if you have any comment or question, please. Any comment or question from the expert panel?
I may add something or may ask for something.
Please, don't hesitate.
Yeah,
we have a few minutes. Yes, please.
Yeah. Thanks, Dr. Ali, for this nice and experienced presentation for your proximal humerus. Appreciate your long experience in this. The thing or my wondering only because for hemiarthroplasty, we see always later when the glenoid is worn up, and this after 1 year or two, the patients usually is always having pain, and we see some patients coming after few years or long years with the glenoid is completely gone, and the patient we have even bone loss. That's why this is many papers we see recently they don't recommend to do hemiarthroplasty, especially in younger age. What's your comment on that?
So listen, I mean, as I said, I am reserving hemiarthroplasty for the more complex cases. So the four-part fracture dislocation, as you know, Dr. Amin, is it's easy to reduce the head back into the joint and put a plate on it, but the study, there are some research has been done about vascular necrosis, about how long that head has been out. And sometimes that head is out for a day, 2 days without a blood supply, especially if there is an anatomical neck fracture. So I think the viability could be a problem. And then if it's a younger patient, a male, yes, you could still consider osteosynthesis. I'm talking about my preference and my experience. But what you talked about, the erosion of the glenoid, yes, it might happen. That's why I'm talking about use a specific system. It's called the platform system, which allows you, just in case, if you need to change that hemi later on with the erosion into a reverse shoulder arthroplasty in 5-10 years down the line, then at least you have that system that easily done. But again, this is dilemma. As I said, it's a doctor choice at the time, and you need to take every case for its merit and study each case. There is nothing called a cookbook type of approach.
That's really
yes,
the reality every day. That proximal humerus in this particular active age is not easy. Due to shortage of time, thank you very much, Dr. Ali, for your nice presentation.
Thank you.
We will move to session 2, and the next paper will be fracture of the proximal humerus in the elderly group, and will be presented by Dr. Stefan Huppert John Von, who is a consultant orthopedic surgeon with wide experience in Europe and UAE, and working in the Health Point Hospital, Abu Dhabi. Dr. Stefan, you are most welcome. Please, the screen for you.
So, how can I? No, this is the end.
So to sum up what happened in the first session, we were talking about the middle age group and the summary of the paper. That at this middle age group, the treatment options are wide, and there is no tailored treatment for. There is no fixed treatment. There is a tailored treatment according to the expertise of the surgeon and also to the patient's needs and conditions. There is a few technical points you have to be considered, and you have to remember always that treatment of the proximal humerus is the treatment of the rotator cuff. You need to put the rotator cuff back in position, which is represented by the tuberosity, so the shoulder will be able to do his proper function. Are you ready, Dr. Stefan?
I'm ready, but I don't know if you can hear me or can see me.
I can hear you, but we are waiting.
To double check all the.
Dr. Stefan, can you make sure to click on share screen?
What do I have to do?
Just share your screen, Dr. Stefan. From the green. Yeah, at the bottom, there is a share screen.
There is no bottom. There is no, I saw
You
it before, but
just to touch the screen again with the arrow, or if it is touchable screen, you will see everything down on the bottom.
I cannot see anything in this.
So in this topic, we are gonna discuss another age group, the age group in the elderly patients, which there are difference in the demand, there are difference in the bone quality, and also different in the other comorbidities. At this age group, we have to consider these 3 points, and to remember always that what we need by treating the proximal humerus fractures is to get the cuff in action. Thank you, Dr. Stefan. We can see your screen.
But you cannot see me.
We need to see the screen. Yes, thank you very much.
Okay,
and thank you for Dr. Najib, who's presenting with you this lecture, and we will waiting the comments. Thank you very much.
Okay, we are talking about proximal humerus fracture in elderly. What means elderly? This is WHO definition is more than 65 years. This is what we are using. The United Union, young old, 60 to 74, old, 75 to 84, and oldest old, more than 85. But we are using the more than 65 years for the elderly people. We have some risk factors we have to keep in mind. This is impaired vision in this age group, using of hearing aids, diabetes, especially patient with polyneuropathy, depressive and dementia of in this age group, use of anticonvulsive medication, and some patients are using alcohol. The assessment is very important. Before we start the treatment, we have to do an assessment. And the main assessment is the X-ray and the CT scan, 2 and 3D. plus minus MRI. MRI is sometimes indicated to do an MRI before we start the treatment to have an idea about the rotator cuff condition. With the X-rays and the CT scan, we can talk about the pattern of the fracture and the displacement. And the treatment is, we will follow the images. The age is important. Comorbidities are important. Anticipated demands of the patient, the compliance of the patient, and finally, the surgeon's experience. We are not talking anymore about classification. Dr. Ali did it already. I want to highlight again surgical column fractures and anatomical column fractures, and the importance of the greater and lesser tuberosity. The trend has been to move away from the fracture classification schemes to concentrate more on the patient's characteristics and expectations in the last years. This is a patient, 66 years old. He had had a bicycle injury. There was no comorbidity, and he wanted to go back to his physical activity as soon as possible. And this is a patient with a moderate displaced column, surgical column fracture in the 2D reconstruction, and the 3D reconstruction can be seen. And we stabilized this fracture with a simple ORIF with plate and screws. Another patient, very active, 64 years old male, fall on sailboat, but he has a lot of sporting ambitions. He was doing kite surfing and so on. And for this patient, we decided, of course, to do a stabilization with an open reduction and plate fixation to give the patient the option to go back to his sportive activity as soon as possible. For these cases, we are using very often the peak plate with a very good option to see the fracture after the operation. And the plate can be removed with the titanium screws as soon as the fracture is healed, if the patient wants to be removed. Sometimes we are removed, most of the patient, of course, doesn't need to remove the plate. This is another patient. She is 76 years old lady with a fall in the shower at home, no comorbidities, and she is a very ambitious amateur tango dancer, and she wants to go back to her hobby as soon as possible. And she went back to her hobby as a tango dancer about 4 months after the operation. The indication for non-operative treatment, surgical neck fractures with good contact and no gross instability, greater and lesser tuberosity fractures with displacement less than 1 centimeter, and overlap less than 20% with the head. And of course, for frail, elderly patients with contraindication for anesthesia. This is a patient, 63 years old, fall of uneven ground in the street, no instability, no secondary displacement. So we could do the conservative treatment. This is the X-ray of the day of surgery, of the injury, 2D and 3D reconstruction with the CT scan, and nicely healing after 4 months. Another patient, 65 years old male, fall while jogging, malfunction of the supraspinatus tendon, and without rotator cuff tear in the MRI. We did an MRI to find out if the rotator cuff is intact or not. The rotator cuff is intact, only the displacement of the greater tuberosity leads to this instability, if this rotator cuff insufficiency. The fracture was treated by 2 screws, open reduction, and screw fixation. The contraindications for operative treatment are the open fractures, associated vascular injuries. They are not very common, but there are polytrauma patient and association with disruption of the superior shoulder suspensory complex, the so-called floating shoulder, with a rupture of all the superior ligament and muscular structures, and of course, pathological fractures. The management of non-operative treatment for all the patients is the arm sling, and clinical and radiological follow-ups after 1, 2, 4, and 6 weeks. We start the active assisted exercises of the shoulder from the week 1. Almost immediately after, maybe after a few days after the injury, soon the initial pain is gone. We start to show the patient how to do the active assisted exercises. The arm sling will be kept for 4 to 6 weeks, but not, if any possible, not longer, to avoid for limited range of motion frozen shoulder. These are the 4 exercises for the patient from the beginning, from left to right, closing and open the fist to improve the blood circulation, lifting up the shoulder in the without movement of the scapula, without movement of the shoulder joint. The next is the flexion and extension of the elbow to avoid any kind of stiffness and pain sensation in the elbow joint. And the last one is the active assisted abduction, anteduction of the shoulder joint, but give the patient even the option to know how big is the pain, how is the pain going down by week. Now we have some studies, comparison between the operative and non-operative treatment for proximal humerus fractures in elderly. Many of the studies found no significant differences between the functional outcome for operative and non-operative treatment in patient above the age of 65. Many studies reported high complication rate in the operative group. Both tension band and locking plates systems did not provide significant benefits over non-treatment. This is a study published in 2015 in the Acta Orthopedica with a systemic review. This is not our, even I think Dr. Loai, Dr. Ali, we have different results in our patients group, because we are very aggressive with the post-operative rehabilitation. We don't want to immobilize the patient for longer than maximum 6 weeks. The last point was treatment of 4-part fractures with hemiarthroplasty found that scores for the life quality of life were significantly better than non-operative treatment, but the complication rate were high as well. There is in the meta-analysis published in 2017 no difference in functional outcomes observed between surgical and non-surgical group. Patient reported a quality of life significantly higher in the surgical group. This is our experience as well. The next point, what I would like to talk about is the intramedullary nailing of proximal humerus fracture. This fracture happened mainly in younger people, not in people above 65 years. And compared with the locking plates fixation, there is no conclusive evidence can be seen to suggest one technique is better than the other. But in our experience, especially the simple column chirurgicum surgical column fracture is the very minor invasive approach to the proximal humerus can be an advantage compared to the plate fixation. The indication for shoulder arthroplasty. This is for very similar to that to the statements of Dr. Ali. Head depression fractures involving more than 40 to 50% of the articular surface. Fracture dislocation with shaft head separation, plus 1 or 2 tuberosity fractures. Valgus impacted fracture with fracture and displacement of both tuberosities. Very old patient with an osteoporosis, comminution of the greater tuberosity, calcar destroyment and medial hinge disruption, and the vascular necrosis after surgery. This is a patient, we did the operation last year, female, 74 years, fall on stairs, diabetes type 2, hypertension, osteoporosis. She came about 5 days after the injury to us with this valgus impacted 4-part fracture. We decided to go for the hemiarthroplasty. And as Dr. Ali pointed out very precisely, the reconstruction of the greater and lesser tuberosity is very important. It needs to be very stable and very to provide a very good healing of these tuberosities. Otherwise, the fracture will, the prosthesis will be in the middle of nowhere without bony support. The reverse shoulder arthroplasty. I want to take one, show you one slide. We haven't done this so far. The reverse shoulder arthroplasty was developed for surgical management of osteoarthritis plus rotator cuff tear arthropathy. Since the tuberosity and rotator cuff related complications are the main reason for a poor functional outcome when humeral head prosthesis is implanted for management of proximal humerus fracture, expanding the indication of reverse arthroplasty to proximal humerus fracture seems reasonable in the older, in the elderly people. I want to show you one patient. I treated her about one year ago, and now she came back after 10 months. This was the X-ray and the CT scan of the day of injury. She was recommended to go for either ORIF or prosthesis. She's 70 years old, but she was not willing to do a surgery. And now she is with this result. The X-ray, the fracture is healed in a subluxation, in the inferior subluxation, but the patient is not able to move the right shoulder even 1 degree. She takes about, the daughter told me, she takes about 20 to 25 minutes every morning to wear the abaya, and she takes the same time in the evening to remove the abaya in the evening. This is, I think, this is a condition we shouldn't go put it in our target. Proximal humeral fractures in elderly present several challenges that we should be addressed when planning the treatment. Patient compliance and expectations, bone quality, comorbidities, functional requirements, and surgeon's experience are to be put in our calculation. There are differences in technique and strategies to improve the results, and long-term follow-ups are required to validate recommendations and findings of studies comparing the results of non-surgical treatment versus those of different surgical interventions.
Thank you very much
for your attention.
Thank you very much, Dr. Stefan, for your presentation, and thank you for you, Dr. Najib, also. Thank you for the expert panel, but due to shortage of time, we need to move to the third presentation, which is talking about another proximal fracture, but this time we will talk about the fracture of the proximal femur, and the talk will be how to avoid complication when treating such fracture. This will be presented by my friend, Dr. Usama Sha'ar, who is the head of orthopedic department in Burjeel. He's a very expert arthroplasty and trauma surgeon with wide experience in Belgium and Syria, in addition to UAE. Please, Dr. Sha'ar, the screen for you, and you are most welcome. Thank you for accepting the invitation.
Thank you, Dr. Luay. Thank you so much for inviting me. Just allow me to start video because I cannot.
Yeah. Meanwhile, I will just comment and summarize for the people. Yeah,
okay,
please share the screen. So if you want to summarize what the previous two speakers talking about was about proximal humerus fracture. And in young people, fixation with plate and screw, middle age, try to do arthroplasty, and hemi is the best. And the elderly patient, the reverse shoulder is the ideal when the treatment or surgical treatment is indicated. Please, Dr. Usama, go ahead. Thank you very much. We can see your screen.
Thank you. I just want to say today is a special day for me because my youngest son has started his fellowship in orthopedic, and this is his first day, and he is online with us.
Excellent. So, he is most welcome.
Yeah.
Okay, and hopefully we'll see him soon in our webinar.
One more orthopedic surgeon. This subject, I mean, proximal femoral fracture, is very important as for the moment we are seeing more and more fractures. Hip fracture has become the most important public health actually, with 1.6 million every year in the worldwide, and you are expecting by 2050 more than 6 million cases. This is, as you can understand, is a very high cost for the public health. So it's sometimes a very challenging surgery. So we need absolutely to do it right from the beginning, because when it fails, it's a real disaster for the patient. And the failure means pain, means the patient is chair-bounded or bedridden. And as you know, the complication when the patient is bedridden with bed sores, etc. So, and revision can be very difficult. So the best way is to do it right from the beginning. So let's learn together how to do it right from the beginning. This we often hear from the surgeon saying to the patient, you know, the fracture didn't heal because of your age and the poor quality of bone. And this is not totally true, because studies showed that the quality of bone and the age has a little influence only on the results. So to have a good outcome, it's like in exam. We have 6 steps to follow. So the result and the outcome depends on how much you will obtain out of 6. The first step is to identify the type and the complexity of your fracture. And we have oftenly, you know, call from ER saying a neck fracture. They are unable to recognize intertrochanteric, subtrochanteric. So you need absolutely to go also to the classification to look the degree of instability of your fracture. So the neck fracture, I will not lose too much time. Everybody knows this Garden classification from 1 to 4, or Powell's classification according to obliquity of the fracture line. Then if it's intertrochanteric fracture, look also to the classification. There is many classification, but the most used is the AO. So this is classified in 3 types. The A1 is simple oblique plus minus displaced. In the type A2, it's oblique, but involving the medial cortex plus minus comminuted. And the A3 is reverse oblique and with involvement of both medial and lateral cortex and sometimes subtrochanteric fracture. In subtrochanteric fracture, everybody knows that this is the worst, the most difficult to manage, and the highest rate of non-union. And the best classification, the Fielding classification, is purely anatomical, but the best one is again the AO, and it goes with the and the diminution of these fractures. So don't hesitate also to do CT to assess your fracture before going ahead. Now, the next step, step 2, is early management. So early management reduce post-op complication, reduce mortality. There is lower incidence of bed sores, reduce pulmonary complication, shorten the recovery, and reduce the cost. There is one beautiful study comparing the result if you treat after 1 day, 3 days, and 6 days. So after 3 days, the complication are multiplied by 2, and after 6 days is multiplied by 3. The third step now is to choose your implant. So actually on the market during the last 25 years, we have seen a lot of intramedullary devices, and all studies and literature showed that these intramedullary devices are superior in stability and in terms of outcome. But still there is place for extramedullary devices like DHS in simple cases. Now, if you choose intramedullary, you have both options, either screw or helical blade. Biomechanical studies showed that the blade resists better to rotation and translation, but this hasn't been confirmed clinically. And in the literature, the blade is associated with higher rate of failure because of blade penetration and cut out. You have also different option, either 1 or 2 screw. Again, the biomechanical studies showed that the biaxial, that means 2 screws, increase the stability, but this advantage hasn't been reported clinically. However, in revision cases, if you have, for example, a DHS, so you have the cancellous bone in the neck was damaged by the previous screw. So I think in this case, 2 screws can be a good option. Now, the step number 4, we need now to reduce our fracture. We choose our implant and now the reduction. So if you go through the literature, the message coming from this is that the quality of reduction is one of the most important factors to avoid failure, really is mandatory. And the thing that we have absolutely to avoid is varus malalignment. Now, for the valgus, sometimes it's needed. We can do it because it increases the stability in very oblique fracture, and it increases the interfragment compression and the stability of implant. Now, the step number 5, we reduced our fracture. Now we need to start the surgery. So the next very important step is the position of your implant. So the main thing is the screw in the femoral neck. Take a care, special care when you want to place your screw. Take time, don't be in a hurry. We need absolutely to avoid posterior position, proximal position. Put it deep enough and avoid as much you can damage to the soft tissue and the capsule, which means blood supply. Now, the last step, this is also important. It's the choice of the right weight bearing option. So, because, you know, companies tell you always gamma nail or whatever, you can have full weight bearing. This is not always true. It's according to the fracture type, according to the stability of your fixation, the bone quality, and the ability of the patient to follow instructions. Now, if you have 6 on 6, you are successful. But if you have 0 on 6, that means you have complication. And the complication, the main reason for complication is bad choice of implant, as discussed previously, bad reduction, mainly varus malalignment, incorrect position of the screw in the femoral head, damage to the soft tissue and blood supply, comminution and involvement of medial and lateral cortex and the subtrochanteric area. The most common complications are screw cut out, joint penetration, varus collapse, and femoral head avascular necrosis. of course, infection like any other surgery, non-union, malunion, and osteoarthritis. Now, what is the incidence of this failure? As it common, if you look to the literature, it varies between 9 and 24. 24%, it's really huge. It means 1 patient out of 4. So, and some studies here are done, I mean, the correlation between the failure rate and the type of fracture. So as you can see, the failure is higher when it's complex fracture or associated with subtrochanteric fracture. Another serious study about 230 cases, 16.5% of failure. And as you can see here, it is important that in case of a posterior position of the lag screw, the failure rate is up to 27, which means 1 patient out of 3. So now, in case of failure, what to do? You have complication, your surgery failed, you have 2 options, either redo, refix again, or replace. So redo is, of course, the golden standard for young patient. You need to absolutely have on the shelf bone graft. You need a very careful choice of your implant for fixation. This redo is still possible in old patients who are active and have a good bone quality. Now, replacement sometimes is the only choice. This is very good option in old patient and unfortunately in young patient with avascular necrosis or significant damage of the acetabulum due to penetration in the joint. Now, remember, either you do redo or you replace. Remember that the removal of hardware is not always easy. Don't say it's failed, I will get it very easily. Recognize your implant, ask the company to bring the instrumentation to remove the nail or whatever. And you need to have on the shelf always the broken screw removal set. Be ready always to manage your bone loss by bone graft, and if you replace, be prepared with calcar replacement implants. The greater trochanter is always a problem also. It's very important for the stability of your hip and the function. So be prepared with wires, cables, hook plate, trochanteric healing, and hardware have, it's very common problems after surgery. Let's look to a few examples. You see here, the failure is due to a high position of the lag screw in the femoral neck. This has failed and needed to convert to hemiarthroplasty. Here, another case, there is collapse in varus and bed reduction with a high position of the screw. This has failed and penetrated in the joint, and this needed, of course, total hip replacement. This another case, you see the screws are convergent, so not placed correctly, and this has failed and needed total hip replacement. Now here, another complex fracture, and just to give an example of bad choice of implant, the surgeon chose to fix this by DHS. And you can see the X-ray is beautiful, but this is a complex fracture with involvement of the lateral cortex. And look what happened. 6 months later, this patient came to me with this X-ray. You see the CT here, 10 centimeter of shortening. It's equivalent to explosion of the hip as you put a bump in this hip. You see, it's horrible. So I managed to convert this to hemiarthroplasty. Believe me, it was horrible surgery. Dissection was very difficult. You don't recognize where is the artery, where is the sciatic nerve, and to recognize the GT and the fragments. This is another example of 54 years young lady, for 54. She had 3 unsuccessful surgery. The first one was a nail. Then another, she didn't heal. The surgeon tried to remove the nail, but he didn't have the right instrumentation. So as you can see here, he broken the proximal entry of the nail. Then he found another solution. He put a DHS through the nail, and he worked against the biomechanical laws because he forced the plate. The angle is not the same. He forced the plate to the femur, and quickly all the screws was broken. So another surgeon tried to remove this implant, and he wasn't able to remove the nail because the nail was damaged. So finally, I treated this patient. It was difficult to remove the implant, but finally it was successful, and she was walking again after a very difficult revision. This is the X-ray 1 year after and before surgery. No, so home message, manage as early as possible this fracture, plan the surgery, do CT, take your time and choose the right device. Try to obtain the best reduction possible, take time to do it, and take special care when you put your screw, as we said, in the femoral neck. Now, my own opinion, I mean, I know that some people will say, no, it's too much. I prefer hemiarthroplasty in complex fracture with poor quality of bone rather than fixation. I still accept, of course, to fix simple fracture like this one, but you see here in 98 years old male with comminuted fracture, I prefer immediately to go for hemiarthroplasty and fix my GT. And this is, I think, everywhere. The new trend now is to put old patient quickly back to activity with full weight bearing, like in this case, and even in subtrochanteric fracture, you still can do hemiarthroplasty or total hip, and especially in complex and stable fracture, I really prefer hemiarthroplasty, but of course you need to have expertise also in hemiarthroplasty, otherwise fixation is superior. Thank you very much.
Thank you very much, Dr. Usama, for this really fruitful and rich presentation, as usual, for your presentations. And we would like to have one or two questions from the expert panel regarding this topic, if there is any of this expert panel available at the present time. Please, Dr.
Yes.
Ahmad, Dr. Amin, Dr. Safa.
You hear me?
Yeah, Dr. Ahmad, you are most welcome. Please go ahead with your question.
Yeah, thank you, Dr. Osama, for this interesting lecture. I just want to ask you about your experience when we have two fracture, neck, femur, and shaft. Do you like to go for one device, intramedullary device, or do you prefer to do double fixation with two implants? And what your expertise in this?
No, I think the long nail is a good option in such case, because now all nails offer the possibility to put a lag screw in the femoral neck. So this is my opinion is a good option. You can do both together.
Yes. But regarding, the new recommendation from the AO, they like to do dual fixation. Sometimes it's very difficult to put, when you fix the intramedullary nail, it's very hard to reduce the neck fracture. And sometimes the nail, as you said, is difficult to put the nail from in the neck in proper way.
Yeah,
and that's why, yeah.
I think you can compare, I mean, either proximal femoral nail or distal nail. I mean, the difficulty to reduce, in my opinion, is the same. I mean, because once you start, you need to start by reduction. So once your neck is reduced, then you can introduce your guide and then manage to reduce the shaft fracture, and then the nail will do the job. I mean, in my opinion.
Thank you very much, Dr. Usama. Thank you for the question, Dr. Ahmad. I think it's time now to move to our next speaker, Dr. Mustafa Kamal Qutb Ali. He's an eminent pediatric orthopedic surgeon in Burjeel Hospital. He's a qualified and fellowship orthopedic surgeon with wide experience in limb reconstruction and pediatric orthopedic. He will present to us the topic of intramedullary nailing in pediatric to give us tips and tricks and how to do it properly. Please, Dr. Mustafa, the screen for you. Are you around, Dr. Mustafa?
Yes, Dr. Lai. Thanks, Dr. Lai, for this kindly invitation.
You are most welcome.
We are going now to speak about intramedullary nailing in pediatric. Pediatric intramedullary nail include rigid, ender, and Nancy nails. Nancy nails, which also called elastic intramedullary nail or flexible intramedullary nail. Flexible intramedullary nail now is ranked as high conservative treatment in pediatric fracture by using stainless or titanium Nancy nails. Ender nail is similar to Nancy nail as it is stainless in type and have many different diameter, but completely different in concept of fixation and application. As Ender nail depend in intramedullary crowding, as we put many nails inside the medullary cavity until filling of the medulla, which make stabilization of the fracture. While flexible intramedullary nail is a technique rather than an implant. So if I have Nancy nail and I put mini inside the medullary cavity until filling of the medulla, that means I used Ender technique. Nancy nail provides the most physiologically stable environment for fracture healing in pediatric. And from here, we must differentiate between stability and instability, as stability means deformation that could be gained again, but instability means deformation that couldn't be reversed. To understand how flexible intramedullary nail work, we must know that there is a critical strain level which make rupture of different tissue. For example, to pre-granulation tissue, it needs to be stretched by 100%, while fibrous tissue need only 20%. This percent decrease to be 10% in cartilage and to be easy as 2% only for lamellar and cancellous bone. What is the indication of that? All of us know that we have two types of fracture healing. First is primary fracture healing, which need very rigid environment to achieve direct bone formation, and strain must be less than 2%. And if more than that, will never achieve bone formation. But how fracture is healed of anyone who don't have fixation or cast, or even how fracture in animal healed? That what we call secondary fracture healing, which means that there is callus formation, but how bone is formed in this environment that all of us know, which have highly strain level, as patient can feel the movement of the bone, and strain level here for sure more than 2%. So how bone is formed? In start, there is formation of granulation tissue, which increase density of the fracture that decrease gradually the strain level, and once the strain level reach 20%, fibrous tissue start to be formed that make more density, and strain level start to decrease more and more, and when it reach 10%, cartilage start to be formed, and for sure when it reach 2%, we start to have lamellar and cancellous bone. The advantage of this method is rapid method of healing. Method of healing while using Nancy nail is to allow secondary healing by formation of callus, which provides stable environment that it is stable enough to allow rapid healing of the fracture by secondary fracture healing. To promote healing, we must have 3 points. First, tissue preservation. Second is elimination of unneeded mechanical stress. Third is preservation of musculotendinous function. We start to talk about tissue preservation. Tissue preservation to be done in the best way, we must go for closed reduction. That means I will not do open reduction, I will not do stripping of the preosteum, I will not do dissection of blood vessel, I will not do any disruption of fracture hematoma. I have to keep fracture hematoma as it is. Flexible intramedullary nail have the advantage that they are not aggressive to intramedullary canal. So there is no disturbance of intramedullary blood supply. Second point we want to talk about it in flexible intramedullary technique is elimination of unneeded mechanical stress. There is stress sorry, I don't know you hear me?
We hear you. Just go ahead. Thank you very much.
There is stresses which increase fracture healing as compression and tension stress, while other stress which prevent fracture healing like shear and rotational stresses. Method of fixation of fracture is to keep tension and decrease shear and rotational stresses. This happens when I use intramedullary construct. This construct should be formed of two Nancy nails equal in diameter, which give opposing stiffness that decrease rotation and change any shear or rotational stress to compression and tension forces. So how to make stable construct on long bone, like for example, tibia or femur? We must use two nails which equal in diameter, opposing each other with maximum convexity to the fracture side. Diameter of each nail is equal 40% of the medulla. Nancy nail can also be used as 3D construct. For example, one nail we can enter from medial side and anterior into the neck of the femur, while the other nail enter from lateral and end posteriorly in greater trochanter. In fracture post-wound forearm, we cannot put two nails on each bone, but every nail on each bone acts as a nail opposing the other nail. Because of that, it's enough to put only one nail in each bone. After that, we can put plaster for 2 to 3 weeks, while in fractured tibia or femur, no need to put any type of plaster. In fixation of metaphyseal fracture, the aim is to make maximum divergence of the nail at the level of the fracture. This is example of fixation of fracture of proximal humerus using flexible intramedullary nail. Last point of flexible intramedullary technique is preservation of musculotendinous function. While we save muscle from any dissection by using closed reduction technique that make stability. So preservation of the muscle gives stability to the fracture. In same time, while movement, muscles start to contract that make better trophic change and increase blood supply to the bone. Not only that, as contraction of the muscle make also good orientation of the fibers around newly formed callus and newly formed bone. Flexible intramedullary nail to be effective and used in proper way, you should have tissue preservation, elimination of unneeded mechanical stress, preservation of musculotendinous function. Stainless or titanium. When patient is more obese, more older, more weight, we use stainless nail more than titanium nails. Stainless have this advantage as sometimes not move in proper way inside the medulla as titanium flexible intramedullary nail. So to make proper flexible intramedullary nailing technique, I need to have closed insertion, stable construct, preservation of soft tissue, and for sure allow early mobility. This is example of fixation of fracture distal 1/3 femur. Another example for segmented fracture in the femur and fixation of proximal 1/3 femur. Flexible intramedullary nailing is revolution in pediatric fracture management, as it is mini invasive surgery, excellent bony union, restoring external punicellus enough stability to avoid external immobilization and short hospital stay and early rehabilitation. Thank you.
Thank you very much, Dr. Mustafa, for your forward to the points in intramedullary nailing. I have just one question, maybe I missed it. You mentioned something about how you select the size of the intramedullary nailing for each fracture. So how you decide which size for this particular fracture? If you are going to use, let's say, 2 Nancy nail for a fracture mid-shaft femur.
We always go in upper limb to use the diameter 35% of the canal, while in the lower limb, I go to use 40% from the canal. In upper limb,
sorry, Dr. Mustafa, 40% for each nail?
For each nail in the lower limb.
Okay. And 35 for the upper limb for each nail, if you are using 2 nails.
Yes.
All right. Thank you very much. I'm sure there is Dr. Zaid or Dr. Muhammad Al-Baz around, Dr. Safa, if they have any question. Otherwise, we will move quickly to the next speaker. Is there any question from the expert panel or from the...
If you allow me, Dr. Ulay, it's nice to meet you here.
Yeah, good evening, Dr. Muhammad Al-Baz. Good evening. Yes, please go ahead.
Thank you, Dr. Mustafa. That was a very interesting presentation. And I agree with you that the flexible intramedullary nail are a revolution in the management of the pediatric long bone fractures. My question to you regarding the fixation of fracture humerus. Would you like to go with the entry lateral or posterior?
I always go, if the distal humerus, I go from the lateral just down the insertion of the deltoid. If it is proximal, I always go from the lateral side just above the physis of the distal humerus, about 3 centimeters, and try to have the divergent in the head of the humerus.
So if you are going with the retrograde nailing for fracture shaft of the humerus, so you would prefer to go lateral?
I go lateral at least 4 centimeters because the distal area is too much hard to enter just above the physis of the distal humerus.
Perfect. I agree with you, but personally I would go posterior. I think posterior is more easier, and I think if you put the patient prone position, and that will help also in achieving the reduction. But I agree with you, both are valid, but I just want to add the comment of the prone position helps much for achieving the reduction. Thank you, Dr. Mustafa. That was very valid, and
thank you for the
expert. See you physically very soon.
Yeah, thank you both of you, and thank you, Dr. Mustafa. We will move. Let's stick to the agenda, and we will move to the next speaker, who's our close friend, Dr. Muhammad Al-Baz. He's the head of orthopedic department in Midyear Hospital, Abu Dhabi. He has a wide experience in orthopedic surgery in addition to trauma surgery. And his next talk will be presented by him. Please, Dr. Muhammad, thank you for accepting our invitation, and we hope that we will enjoy, as usual, with your nice presentation, which will be today complex idiopathic club foot. Also, you are going to speak about complex things, but I'm sure it will be in the simple way. Thank you very much.
Thank you, Mr. Chairman, Dr. Lai. It's my pleasure always to be with you, and it's my honor to be among the greatest orthopedic surgeons in Abu Dhabi and all over the United Arab Emirates. My presentation today is complex idiopathic clubfoot diagnosis and treatment. These are my content, the content of the presentation. We'll go through introduction of the clubfoot in general, then principles of Ponseti treatment, and then we'll pass through the severe complex clubfoot definition, causes, and treatment. So congenital clubfoot, congenital idiopathic clubfoot is a deformity occurring in otherwise healthy child, and that's why it's in idiopathic. The deformity composed of equinus, cavus, adduction of the forefoot, inversion, and all these deformities occurring at the axis of the talonavicular joint. It's very important in the treatment or defining the clubfoot to identify the head of the talus and to differentiate the head of the talus from the very prominent anterior tuberosity of the calcaneus. So Ponseti treatment, as everybody knows, is the most recent reports using Ponseti method of treatment reported excellent correction with the majority of patients. Most clubfoot corrects within 4 to 6 manipulations, followed by plaster cast application as per Ponseti steps. Ponseti steps, and I'm going to mention now the classic Ponseti before going to the modified Ponseti and treatment of complex clubfoot, reduction of the cavus, adduction and varus deformity correction, and then tender Achilles tenotomy, bracing with or without tibialis anterior transfer. These are a demonstration of the steps of the Ponseti treatment. I usually, before starting my treatment, I just give the trying to make the child or the baby calm down and quiet by giving him the bottle of milk, and then starting correction of the cavus, and then trying to start correction of the forefoot adduction, and then increasing the forefoot adduction by increasing the tibial, the leg foot angles, and put them finally in the maximum abduction. And then once the heel is in neutral position or slightly in valgus, that's timing to go for tender Achilles tenotomy, and then final cast before applying the bracing. So that was the classic Ponseti and the classic simple idiopathic clubfoot. However, small percentage of clubfoot are difficult to treat. They are complex, very severe, and stiffness. So numerous surgeons have performed complete plantar, lateral, medial, and posterior release with questionable results on a long term. So back to the main slide, we have spoken about the introduction of the clubfoot, mentioned the principles of Ponseti treatment, and then now to clubfoot, complex clubfoot. So now to the main subject, what's complex clubfoot? The definition of the complex clubfoot: any complex clubfoot has deformity in the forefoot and in the hind foot. In the forefoot, which this slide demonstrates, this foot is in severe adduction and all metatarsals are in plantar flexion, causing severe cavus. And this severe cavus is complicated also by deep crease across the sole of the foot. This is the deformity of the complex clubfoot in the forefoot. So how about hind foot? Hind foot, it's in severe equinus, causing deep double creases above the heel, as this black arrow demonstrates. The calf muscles are small and the tender Achilles is long and tight, pulling the calcaneus into severe varus. So these are the forefoot and hind foot deformity, which is characteristic to characterize the complex clubfoot from simple clubfoot. So what's the causes of this complex clubfoot? It's either idiopathic or iatrogenic by manipulation of a simple clubfoot by non-experts' hands. And lastly, the frequent cast slippage. And in this presentation, I would like to focus in the frequent cast slippage, because I think from my point of view, it's one of the most common causes producing this complex clubfoot. So how to prevent while casting a simple clubfoot, how to avoid cast slippage during the usual casting and following the Ponseti method of treatment. I personally prefer to use the POP cast rather than the fiber or the plastic one, which make it easy for me to mold the cast over the bony and soft tissue prominences, which really helps if you remodel your cast against the soft tissue and bony prominences. I think that will minimize the chances of cast slippage. First, the heel, the anatomical bony prominences, as well as the tendo Achilles, the curvature of tendo Achilles, and make the plantar aspect of the foot straight, and both medial and lateral malleoli. Following this kind of remodeling over the anatomical structures minimize the cast slippage. However, in some cases, we cannot avoid in chubby children, non-compliant family, sometimes because of the highly irritable child or baby during the process of application of the plaster. This is the picture that we usually face at frequent cast slippage. And here is the how's the complex club foot. It results in small stubby foot with plantar crease, and the whole metatarsals are in severe plantar flexion. So how to treat these? How to treat the complex club foot, which is the main focus of this presentation. Although the forefoot abduction can be corrected easily with 1 or 2 plaster casts, the metatarsals remain in severe plantar flexion, and this is the most important point in treatment of complex clubfoot. How to correct the severely plantar flexed metatarsals. Ponseti had modified his classic way of treatment and to suit the complex clubfoot by these 6 steps. First of all is identification of the head of the talus, then proper cast application, reducing. So first of all, to identify the head of the talus and to reduce the talonavicular joint, and correction of the metatarsal flexion along the axis of the tarso-metatarsal joints. And then tendo-Achilles tenotomy in the usual way. Final cast has some special criteria that I'm going to mention it in a minute. Then bracing. So back to each point of these points. The first one is the identification of the head of the talus. So identification of the head of the talus is done by clear identification of the head of the talus, which is difficult to locate because it's less prominent than the anterior tuberosity of the calcaneus, and that should be easy by an expert hands. Otherwise, if you will try to reduce the anterior tuberosity of the calcaneus, you will turn the simple clubfoot into complex clubfoot. Movement of the subtalar joint, which will be minimal at first, but could be felt after removal of the 2nd or 3rd plaster cast. So identification of the head of the talus was the first point in modified Ponseti treatment. The second point is to correction of the forefoot abduction. Correction of the forefoot abduction while applying the cotton and plaster cast bandage. The index finger should be resting over the posterior aspect of the lateral malleus, as indicated by the black arrow. The thumb of the same hand applies counter pressure over the lateral aspect of the head of the talus, and the other hand moving the forefoot into abduction. Number 3, which is the challenging point in treatment of and modified Ponseti and to suit the complex clubfoot, is the correction of the metatarsal flexion. Abduction of the forefoot was corrected easily after 1 or 2 manipulations. However, the metatarsal remained in severe plantar flexion, and the hindfoot is in severe equinus. So how to correct then? And I think that this slide is the most important slide in this presentation to how to correct the metatarsal flexion. Hyperflexion of the metatarsal and the rigid equinus were corrected simultaneously by grasping the foot by the ankle with both hands, while the thumb underneath the metatarsals push the foot into dorsiflexion. while the assistant is stabilizing the knee end flexion. So we have 3 steps to correct the metatarsal flexion. Grasping the foot and the ankle with both hands while the thumb pushing the metatarsal and the dorsiflexion, and most important is to stabilize the knee end flexion. Modified Ponseti treatment pass through the tendo Achilles tenotomy, and that's usually done in a usual way. However, I would like to stress, if the complex club foot was turned from simple one and tenotomy was done before, there is no harm to repeat the tenotomy and should be done as in a percutaneous usual way. Final cast, and the final cast in this kind of complex club foot should be taken, some points should be taken in consideration to suit this complex deformity, to put below knee slab before applying the cast to maintain the forefoot dorsiflexion, and to apply also anterior short knee slab to maintain the knee in acute flexion. Acute flexion of the knee should be around 110 degrees. And again, the assistant holds the knee in acute flexion. A patient requires an average of 5 casts for full correction. Foot abduction brace doesn't make, there was no difference between applying the foot abduction brace between simple and complex club foot. The usual protocol of applying day and night for around 4 to 6 months, and then night time for around 12 hours for around 2 to 3 years, according to the severity of deformity and to the response of the feet. Full correction of the foot with plantar grade foot and neutral heel with some overcorrection in valgus. Foot turn it into normal and the plantar crease turn it into small dimple, which is a sign of successful treatment. Again, now finally, conclusion and summary. Orthopedist familiar with treatment of congenital club foot knows that there is a small percentage of a club feet which are stiff and resistant to manipulation, and it's very, very, very crucial and very important to identify whether you are dealing with a simple or complex club foot. Criteria of complex club foot include severe abduction, all metatarsals are in plantarflexion, causing severe cavus and deep crease across the sole of the foot, severe equinus causing deep double creases above the heel. The treatment of such complex deformity include proper identification of the head of the talus, which is usually overridden by the anterior tuberosity of the calcaneus, and is very important to identify between these two both bony prominences. Correction of the hyperflexed metatarsals, as mentioned, the technique is mentioned before. Maintain the correction with a long leg cast, with the knee flexed, supported with anterior and posterior splints. Acknowledgement to Professor Eganshi Ponseti, the leader of the revolution in the treatment of clubfoot. Thank you very much.
Thank you very much, Dr. Muhammad, for a nice presentation, and thank you for sticking to the time. I will leave the expert panel question if they have. I wonder if Dr. Zaid or Dr. Mustafa or Dr. Usama around for raising some questions.
Can you hear me?
Most welcome, Dr. Zaid.
Yeah, thank you, Dr. Loy. Dr. Muhammad, amazing presentation. But
thank you, Dr. Zaid.
The complex clubfoot. So one of the things which I wanted to ask you, we are experiencing sometimes that our colleagues, they try to correct, let's say, a simple clubfoot, and it fails. Then they say, okay, this is not correctable, and let's do the surgery. Like, for example, a posterior medial release. What do you think about that?
Thank you, Dr. Zaid. Thank you, first of all, for being with us, and thank you for your question. I think I have mentioned that in the beginning of my presentation, that usually some of surgeons take the decision very quickly to go for some sort of lateral, medial, posterior, posteromedial releases. However, this decision is questionable in long-term results, and in my opinion, I think it turned the foot into more stiffness and more adhesions and more fibrous adhesions. So I think, as per Ponseti treatment, we have to keep sticking to Ponseti treatment, and he himself had modified his way of treatment from simple to complex, because I think that every single problem in treatment of simple clubfoot having solution with Ponseti.
Okay. There's a place for a second question?
Yes, please, Dr. Zaid, please.
So I noticed in one of your slides, the abduction brace, it was around 45 degrees.
I usually start my brace after removing the final cast. I usually start at 60 degrees, to be honest, and that will be 60 degrees till the first 3 to 4 months, and then according to the response of the foot, I usually start to reduce the angle of abduction gradually. However, I think the angle is something to be tailored according to the deformity of the foot and according to the success of the treatment. So personally, I think I should start at 60 and then reducing that gradually according to the response.
Thank you.
Dr. Muhammad, there is a question from the participants. They are asking about a lot of deformity has been picked up antenatally. So when do you start your treatment after delivery?
I start as soon as possible. I personally, some have been called so many times to see these deformities after delivery, and I usually give them appointment to my clinic as soon as possible, within days after delivery. So there is no point to delay the treatment as long as the diagnosis had made clear.
Thank you very much. Very clear answer and straightforward. Thank you for the participant for their question. And we can reach at now above 700 participants, which is really a good number. And we will move straight forward to the next talk by my best friend, Dr. Zaid Al-Ubaidi, which I know him personally. We work together for a long period of time. He's an expert surgeon with wide experience and qualification from Europe and North America. And we work together in Sheikh Khalifa Medical City at the golden time. He's now moved to Dubai, but still we are in contact all the time. He's the head of pediatric orthopedic and spine treatment unit in Al Zahra Hospital, Dubai. He will talk today about pediatric elbow injuries, and as he used to present it, usually straightforward, nice and simple, fruitful presentation. Thank you, Dr. Zaid, for your participation with us, and we hope that we will see you always with us. Thank you very much, Dr. Zaid.
Sorry for the invitation. It's an honor to be with my colleagues and amazing presentations. And just to add to the comment to Dr. Mohammed Elbaz about the clubfoot, sometimes we say that we wish that the patient is in breech presentation, so the feet will come out first. So we start the casting as soon as the foot. So
that's great. Thank you.
So I'm going to talk about the pediatric elbow injuries here. Just to think about the ossification, because, you know, like always, this is the tricky part. And I think that a lot of colleagues, they know the cryotone. And just to mention that, especially the E here, please be aware of that. I have seen 2 cases. One of them I succeeded to get the patient out of surgery, but unfortunately one was operated already on a mistake, and it wasn't a mistake from our colleagues. Even the radiologist reported it as a fracture. So this is a table where I would encourage my colleagues just not to memorize it, just to look through it when they have a pediatric elbow, because it is a very complex indeed regarding the radiology. So regarding the elbow fractures in children, it's very common injuries, approximately 65 with pediatric trauma. Of course, radiographic assessment is difficult for non-peds orthopedists. Sometimes, as I mentioned, because of the complexity and variability of the facial anatomy and development. A thorough physical examination, of course, is essential. Neurovascular injuries can occur before and after reduction, so this needs to be assessed. Compartment syndromes are rare with elbow trauma, but can occur. And if it didn't occur because of the fracture, sometimes it occurred because we put a tight or a cast, not taking into consideration the swelling that's gonna come afterward. So for the physical examination, the children usually will not, move the elbow if there's a fracture present. Sometimes even if there is no fracture, we know like kids, small kids, they are so scared. Sometimes it's just a pulled elbow and they will not move it. But we need to, be patient with them. And it could be, like the case for a non-displaced fracture. Swelling about the elbow is a consistent feature except for non-displaced fracture. So it's not always when there is a swelling, there is a fracture, and it's not always when there is no swelling, there is no fracture. Complete vascular exam is necessary, especially in supracondylar fractures. Doppler may be helpful to document the vascular status. Neurological exam is essential as nerve injuries are common. And in most cases, full recovery can be expected, especially after doing a good reduction. So always palpate the arm and forearm for signs of compartment syndrome. Do a thorough documentation of all findings is very, very important. A simple record of neurovascular status is intact is unacceptable. Individual assessment and recording of motor, sensory, and vascular function is essential. So for the neurovascular status, I just would like to mention that once I was called for a 5-year-old girl who fell with a glass in her hand, and she had a small cut in the hand, and it was reported neurovascular status is intact. And what was intact, it was a partial injury to the ulnar nerve, and the ulnar artery and the radial artery were intact. That's all what was intact. So be patient when you're examining the kids. For radiographic anatomy landmarks, we know something called the Bowman's angle is formed by the line perpendicular to the axis of the humerus and a line that goes through the physis of the capitulum. And this is important to know about the displacement and to assess your displacement if it's acceptable or not acceptable, but also to assess your reduction. So anterior humeral line, I think we all know that when we reduce for example, especially the extension type supracondylar fractures, we look at that. We would like to see this part flexed a bit to the front. And we would like to imagine the line going through the center of the capitulum. And always remember it as a hockey stick. The physis of the capitulum is usually wider posteriorly compared to the anterior portion of the physis. And what we mean is this part, as you can see, is a bit wider. Here is closed, and this is normal. All these features I'm trying to make you familiar with, because these what makes a lot of you confused when you're in the surgery, in the middle of the surgery, and this is normal, not normal. Is it fracture or is it just physiological? So radiocapitular line should intersect the capitulum in all views. and make it a habit to evaluate that. So, sorry, when we say the radiocapitellar line, we mean a line going through the center of the radius and the radial head and goes into the center of the capitellum. And remember, these are basics, I know, but I have seen few cases that comes to me with a fracture, for example, of the shaft ulna or distal ulna, just a simple fracture. And then we discover later on that there is a radial head dislocation. So most common fractures around the elbow in children is the supracondylar fractures. It's 60% of elbow fractures. 95% are extension type injuries. And produce posterior angulation, displacement of the distal fragment, and occurs from a fall on outstretched hand. Because of the flexibility of the elbow of the kids, it will be hyperextended, and that will impact all the force from the forearm through the distal radius and will push that part of the distal, of the distal humerus, will push that part of the distal humerus to the posterior part, producing the extension type. It may be associated with distal radius or forearm fracture. So always, don't fall into what I call satisfaction of search. You find one fracture and then you're satisfied. Always look for something else. So classification, we have the simple classification. Type 1 is non-displaced. Type 2 is angulated, displaced, but there is some contact of the part. And type 3, there is complete displacement with no contact between the fragments or the part. And there are fracture which was also modified into these types. And I don't want to go into all the details, but I want just to say that this is a simple, and I think for most of my colleagues, they know this classification. And I used to say classifications are good, but you have to put in mind there are two kinds of classification, two types of classification. Fracture that can be treated conservatively and fracture that needs to be operated on. If you keep this in mind, this will be very simple for you. So the fat pad sign, we have heard about it, and it was described from 50s by Norell. It stands for radiological visualization of the intracapsular but extrasynovial posterior and anterior fatty tissue. Many studies have conducted, but still no consensus regarding the percentage of associated occult fracture. So just to give you a small review of it, you can see the anterior fat pad, it might be present, but the posterior fat pad, if it's present, then this is a positive fat pad sign. Many studies having a mixed group of patients regarding the age and the injury of energy of trauma, there were no definite treatment protocol when positive fat pad sign is found. So this is, for example, a simple case. This is a positive fat pad, and you can see this is a negative fat pad. There is a slight shadow here, but posteriorly it's not present. So we thought about all the studies. We went through all the studies, and like I mentioned, the studies were mixed groups. They were just looking through the x-rays. Some studies just looking at the x-ray, then repeat the x-ray after a few weeks to see if there is an occult fracture or not. And this was not the way to go through it. So we conducted a prospective study where we took 26 patients. It was 10 males, 16 females, and this is the mean age. And what we did, the patients, when they came to the emergency room and they had a positive fat pad sign, we went through also the positive fat pad sign by myself and a musculoskeletal radiologist, Dr. Tolfing. And then those patients which had positive fat pad sign, we took them to the MRI as soon as possible. And this was the time we did the MRI. And the MRI showed 6 occult fractures, which accounts for 23%. And the conclusion of the study is that the presence of a positive fat pad sign is not synonymous with occult fracture, and finding occult fracture on MRI does not alter the final treatment of these patients. So on the basis of this study and the review of all the other studies, pediatric patients with positive fat pad sign on conventional radiography could be treated with a cast or a backslap for 2 to 3 weeks, and extraclinical or radiological controls did not seem to be indicated. I would say here with caution that if my colleagues would like to see the patient after 1 week for clinical assessment or just to take another x-ray is fine. But I really believe that this is more than enough, and it didn't seem that it needs more than that. So this is one of the MRIs, as you can see, how it looks on the normal and how it looks on the patient with a positive fat pad sign. So associated injuries, nerve injuries incidence is high, between 7 and 16%, median and radial and ulnar nerve. Anterior interosseous nerve injury is most common injured nerve. In many cases, assessment of nerve integrity is limited. Children are not always cooperative, can scream and shout, and we all know this. So carefully document pre-manipulation exam, post-manipulation neurological deficit can alter the decision-making. So what about the lateral condylar fracture? It's a common fracture. It's approximately 50% of elbow trauma in children, usually occur from a fall on outstretched arm, and that classification according to Jacob, as you can see, type 1, type 2, and type 3. Okay, and like I said, I would like to keep it simple. I have, let's say, the UAE classification, let's call it, that there are 2 types of fracture. One you treated conservatively, and one that needs to be operated. So what about the medial epicondyle fracture? It represents 5 to 10% of pediatric elbow fractures. It occurs with valgus stress to the elbow and frequently associated with an elbow dislocation. Be aware that if you have a child with elbow dislocation, I would say, in my experience, 90% of them would have this kind of fracture. And you have to look for this part because sometimes it could be entrapped inside the joint after you reduce the dislocation. So I would just show you this slide, okay, that this is what I meant. You can see this is after reduction, and this is the medial epicondyle is entrapped. And of course, this is, you know, a case where you need to take the patient for surgery. Example of non-operative treatment for medial epicondyle. This is a 12-year-old female weight-bearing athlete treated non-operatively, full range of motion, no valgus, you know, instability at 6 weeks, and she returned to competition at 8 weeks. So now what I'm trying to say here, we're talking about the rule of 5 millimeters, because most of the studies, or most of our colleagues, they say if it's more than 5 millimeters, you have to go for fixation. I tend to say, you know, think out of the box. Don't think always black and white. It's not black and white. And why this 5 millimeters? So what if it's 6 millimeter? What if it's 5.5 millimeters? So, you know, this case, you know, we left it, and right now I think it's all over. And this case, I had it, I think, more than 12 years ago. I think I had it like, back in Denmark. This is from Denmark. And, you know, right now, I think we all agree that this 5 millimeter rule doesn't exist anymore. So olecranon fracture, relatively rare fracture in children, increased incidence in children with osteogenesis imperfecta, of course, could be associated with elbow subluxation. The diagnosis may be difficult in younger child. Olecranon does not ossify until 9 years. And in older children, the fracture may occur through the olecranon physis. Anatomical reduction is necessary. And here, I would like to show you, this is, you know, my method of fixation, because this fracture, we agree, it needs open reduction and internal fixation. So what I do, I put these 2 K wires, and there is a tension band, which I do with the Vicryl, and these K wires, I leave them outside the skin, and then I can remove these K wires out in the clinic, and in this way, I don't need to operate the child again. Radial neck fracture, rare entity of all pediatric fracture, can be challenging. There are different methods. Metasud described a very nice method in the 80s with the centromedullary technique. And he described in 93 the same technique using the ESIN, the elastic stable intramedullary nails. And since 2004, this technique has been used in our department back in Denmark. So I just want to go quick because I think I'm over my time a little bit. This is the classification according to Steele. And you can see that it's according to the displacement and the angulation. And we went also through this, because we wanted to see our cases, and we did a study about the centromedullary technique. Like this is a case where we can see it's completely displaced, and we fix it with, this is close reduction and with the centromedullary technique. And remember in this x-ray, okay, this is one of the cases which came to me after 3 months. This is the radial head, okay? So remember that it could be like displaced and posteriorly. So I have to jump through the dislocation. This is what we know, the Montague fracture. So remember what we talked about it in the beginning, that you have always to look for the radiocapitular line. So this is the end of my presentation. Sorry, Dr. Loay, I had to use a couple of minutes because it's a very big subject, but I hope that this will cover most of the important parts. Dr. Loay, are you there? Okay.
Yes,
so
I'm here. Thank you very much, Dr. Zaid, for your very nice lecture as usual. And your time is just good, and we are still on the line. I wonder if any question from the expert panel, Dr. Amin, Dr. Muhammad, Dr. Mustafa, Dr. Haider, is any one of them? We have still time for 1 or 2 questions, please.
Okay. The Dr. Zaid's nice presentation, very concise and very fast you are going through. I may ask one question, which is sometimes coming in the mind of some of our audience. This is what for the supracondylar fracture, what is the parameters which is acceptable and not accepted when you are making reduction and fixation for the supracondylar fracture in general?
Thank you, Dr. Amin. So your question is about the reduction when I accept it and when I say it's not.
Yes, exactly. This is a parameter. This is what here, when you reach to it, you accept, and some other things, parameters not acceptable in supracondylar, and why, please?
So I would say varus valgus, for me, more than 5 degrees is not acceptable. And for flexion and extension, you can accept a bit. You can accept, 10, 15 degrees is okay, especially in small kids, it will remodulate because we know anything in the same direction of the movement, it remodel very well. Regarding the rotation, the rotation, there is a lot of talks about it, but I would say, also like around 10 degrees is okay, especially in small kids, because this will alter the internal external rotation, but it wouldn't affect the range of motion. But varus valgus, 5 degrees for me is the maximum.
Thank you.
I'm sorry, I have to go through, very quick because it is a very big subject.
Yes. It was fine, Dr. Zaid. Any more questions? Because we have just 1 minute to move to the next speaker. There is one question for you, Dr. Zaid, but the participant wants you to answer the question. So yes. I cannot answer him. He wants Dr. Zaid to answer it. It is in the Q&A down. So please be kind and answer him. I think it's time now to move to the next speaker, Dr. Haidar Saleh Al-Sadi. Thank you, Dr. Saleh, for accepting our invitation. Dr. Saleh is a consultant orthopedic and trauma and spine surgery in Rashid Hospital, and he is associated professor in Dubai Medical University, very active doctor on scientific basis, and also a very eminent surgeon for trauma and spine. And he's very famous for his running the AO course and participating on a lot of meetings in Dubai and internationally. Dr. Saleh will speak today about non-union treatments, and I hope you will enjoy it. Please, Dr. Saleh, this screen for you.
Dr. Jaban, thank you very much. Thank you very much for your invitation and for this nice introduction. I will talk about non-union treatment. I hope now you can see my screen. Now,
yes, it's clear.
This is complex issue, as you know. This is the first case we will talk about. This 42-year-old male. He presented with a fracture of the proximal femur, with a fracture of the femoral neck, and it is open fracture, and there are some missing bone, and the surgeon decided to fix it in this way. This is the second case. This is 33-year-old male involved road traffic accident, presented with the closed distal femoral fracture, fixed in this way with the distal femoral plate LCP. And our third case, this is a 25-year-old man with body mass index 39, has involvement in the road traffic accident and presented with this femoral shaft fracture. Of course, because he's obese patient, we did for him a distal femoral nail in this way. So the surgeon did distal femoral nail in this way. So please, what do you think? Which one of these fractures will go for non-union? Please write it in your question and answer field, and just write the number, which one you think this will go for non-union. If we go through it, for the first case, this patient, this post-op X-ray, this after 3 months, and after 1 year, there is good healing of the bone in accepted manner, and the patient has no pain and has full weight bearing mobilization. If we go to the second case, after 9 months, still there is non-union, 9-month non-union with this fixation. And the third case, after 1 year, there is no union, non-union of the femur. So in this presentation, we'll try to know why some fracture fixation goes to non-union and some not will unite. So we list factors leading to non-union, understand the mechanical causes of delayed union and non-union, and discuss how these complications might be avoided in fracture management, and outline the principle of treatment of non-union. Now, definition of non-union is changed from the classic definition. You know, classic definition of non-union is depend on the time to consolidate the bone. Now, delayed union is the failure to consolidate within the normally expected time for fracture types and location, while non-union is the opinion of the treating surgeon that healing will not occur without further intervention. So non-union now is not related to time, is related to the follow-up of the patient and how the surgeon feel towards that patient. Pseudoarthrosis is formation of a false joint where a fibrocartilaginous cavity is lined with synovial membrane. Now, fracture healing, as you know, the primary bone healing with osteonal reconstruction is not a really healing. It's the same job of the bone, of daily job. It's remodeling. You know, the osteoblast and osteoclast, they have daily job of adding bone or removing bone. And this is what happened when we are talking with the primary bone healing. While secondary bone healing, this is the true healing process, is driven by an inflammatory response to injury and described in 4 stages, as you know. Start with the inflammation, then soft callus, hard callus, then remodeling. So there is theoretical, what we call bone healing organ. This is temporary structure formed when we have secondary bone healing, not primary bone healing. This postulating its existence helps us understand reasons of failure of bone healing. Bone healing organ is derived from fracture hematoma and migrating pluripotential stem cells. Appropriate mechanical environment needed to form good bone healing organ. And this is very, very important. We cannot always blame nature for non-union. There are many of mechanical causes led by the surgeon itself. So bone healing organ is the callus formation. And of course, bone healing organ has many factors, has adverse effect on it, like it's open fracture, high energy, like soft tissue disruption, subcutaneous bone, intra-articular bone. The surgery itself is another damage to the bone healing organ. And also affected by presence of carbon monoxide, like a smoker patient, poor blood supply, like patient with microvascular disease, if the patient has infection, or if there is high strain environment, that means instability. Now, the types of tissue formed is depend on the mechanical environment. That means interfragmentary strain theory of a fracture healing done by Mr. Stephen Perrin in 1975. Strain, what's strain? Strain, it is change of length over length, so measured in percentage. There is no unit for strain. Tissue cannot be formed by the bone healing organ if the interfragmentary strain is greater than the yield tolerance of the tissue concerned. So what's the yield tolerance? Now, if there is any movement at the fracture parts more than 2%, no bone can be formed. To have a bone, we need the movement 2% and less. So from 2% till 10%, what will form? No bone will form, but cartilage will be formed. If more than 10% till 100% of strain, that means the granulation tissue will be formed. So the strain is the formation of the tissue in the gap. That means it's change of the length over the length by percentage. So there is big difference between the strain for the simple fracture when I have only two parts of the fracture, or between the complex comminuted fracture. Different strain, so you need different approach. Now, if I have a small gap, better to have a compression, then achieve absolute stability, no movement at the fracture site, then the healing will happen. Small gap, we need to do compression, achieve absolute stability, no movement, low strain, less than 2%, direct healing, then no callus. If a small gap, but there is no compression, and you want to do relative stability, there is movement and high strain, then I expect poor healing if I use relative stability for a simple fracture. Now, if there is large gap, then a bridging technique, relative stability is the best option, because movement with low strain would lead to indirect healing and callus formation, because all these small pieces have a small movement. So generally strain will be less than 2%, which is the yield to form the bone. Remember, we cannot diagnose non-union only from radiological examination. X-ray are blocked by the dense nuclei from atoms. In bony tissue, there are calcium ions. Callus is not a radio-opaque. Intermineralization occurs. So mineralization cannot occur in any zone of a fracture gap until the local strain is 2% or less. Amount and distribution of callus is a radiological marker of the strain environment at the fracture. Now, look for these two X-rays. These, both of them, they are young males, both of them in their 20s age, and both of them, they have a previous surgery. Look, the X-ray on your left side, we think this is atrophic non-union. In reality, this patient has very unstable fixation before fixation removed that has large amount of movement, so no bone formed at all. What happened is only granulation tissue. And on your right hand, when you have the plate, there is some stability, little stability. So give you some callus formation without union. So what happened? You can see callus, but that doesn't mean that on your left hand it is avascular, on your right hand it's vascular. Both of them has mechanical cause of non-union, and when opened on, there is good vascularity of both of them, and revision surgery done for both of them, and no need even for bone graft, they have good healing. So what's the vascular hypertrophic non-union? There is major displacement of a fracture with destruction of the fragment without accurate opposition of the fragment. So what's the treatment of non-union? If the patient has nail in the bone, it's better to do exchange nailing. If the patient has a plate, then better to have compression plating instead of the plate removed. Sometimes you need to use the circular fixator. Bone graft is questionable, and non-surgical treatment, maybe this is in the future, will be our first option. Now, exchange nailing. First option in diaphysa femoral and tibial non-union. Non-union occurs because of instability or malreduction. Both must be addressed to heal the fracture. Now, compression plating, if you want to achieve implant, must be preloaded to achieve stabilization compression force. Now, pre-bending the plate and using load screws in the elliptical hole of the LCB may have to be supplemented with a tension or compression device. Remember, when you come for simple fracture, non-union, and you want to achieve compression, lag screw is not enough, not like a primary surgery. Better to have achieved preloading a compression plate better than lag screw to achieve good compression at the fracture site. You can see here, there is a compression plate. This is the X-ray on your left side. There is felt fixation with non-union, revision done with a compression plate. The compression achieved then within 6 months, there is complete consolidation at the fracture site. Circular fixator, we use it to achieve compression at the fracture site. The advantage of a transferring force along the mechanical axis of the bone can store large amount of energy, so large preload. You look, and on your left side, there is fibular osteotomy done, piece of the fibula removed, and exchange nailing with thicker nail done. Then we add for it the circular external fixator to achieve compression at the fracture site, then removed after 3 months and kept only the nail, and good consolidation happened. Now, avascular non-union result from poor vascularity, plus minus and stability. Usually with open plating, with this open fracture, careless handling of the fracture, and the solution is bone graft. Bone graft, now many surgeons no longer use cancellous bone graft, cancellous autogenous bone graft. Now we have a lot of either synthetic bone graft or it is allograft. It is give the same result of autograft and less morbidity and less pain. Sometimes the patient gets pain from the iliac crest site more than the pain of the surgery. Removing existing implant and restoring alignment lead to formation of the fresh bone healing organ. Considerable doubt as to whether the benefit outweigh the extra morbidity with bone graft. Now, what's about non-surgical treatment? Non-surgical treatment, structure of bone is known and understand right down to the anatomical level. It must be possible to influence the chemical reaction or manipulate the microscopic physical critical environment. However, clinical relevant experimental data is extremely difficult to produce. That means you encourage bone healing by give ultrasound wave. This is, they think, will be in the future more popular. Now we come back to our cases. Why this developed non-union? This 33 years old male, road traffic accident, pedestrian. So what's the problem with this fixation? If you go to this fixation, look, there is no closure of the fracture site. So still there is gap. So there is not, this is not relative stability, not absolute stability. All the screws are locked screws. The fracture cannot do compression. And if you decide to do bridging, it's supposed to be 1/3 of the length of the plate. This is not a real bridging. It is very short distance of a bridging. So 9 months post-op, most of the fracture of the screws are broken because there is a high pressure on the plate, and you know this is locking screws to break from its connection to the plate. All these screws are broken screws. So remember, bridging technique, it's bridging. Now, if you have comminuted fracture, screw is supposed to be placed as close as to the fracture site. While if you have simple fracture, you need at least leave 1 to 2 holes on each side. Otherwise, there is no bridging. If you don't close the gap and you put 2 screws just near to the fracture site, you cannot achieve union because you didn't close the gap. And remember, bridge like any bridge. If you want to put a bridge on the river, you need to be on the 2 sides of the river. The same thing. If you have comminuted fracture, you need to be your stand, just your screw just on the river. But if you have simple fracture, you need to give the space. So revision surgery done. You see in revision surgery, more space given. This is hybrid fixation. That means all the distal screws are locking screws, while all the proximal screws are conventional screws. And this is just 1 year post-op. You can see how it's healed with good consolidation. Now, this 25 years old male, motorbike accident, body mass index 39, DFN done. Look, only dynamic screw inserted and there is no static screw inserted. The surgeon thought this will give you more compression at the fracture site. Yeah, this can be achieved if you have really transverse fracture, but if you have like this oblique fracture, this gives more instability at the fracture site and lead to more movement at the fracture site, more than the 2% which is we needed to achieve the bone healing. So 3 months post-op, there is no sign of healing. 6 months post-op, there is no sign of healing at all. So 1 year post-op, still no sign of healing. So what we will do? Revision surgery. Revision by reamed, exchange, nailing, exchange reamed nail with wider nail. But the surgeon with reaming, except with revision, also put only dynamic screw. So what happened? Another 1 year, and there is no healing at all. It's still non-union. So what can we do? This is the second time done for him, exchange nailing, and there is no healing. He's young. He's young. So still has pain with walking. So what can we do? This is the CT. So Albert Einstein say insanity, doing the same thing over and over again and expecting different results. This needs different approach. So revision surgery with dynamic and static screw and add a plate on the nail. And this is the technique which is very efficient. 6 months post-op second revision. And this is 1 year post-op second revision with very good consolidation. So in this study, showed that if you add a plate on the nail and the nail in place will give good result. And to prevent non-union, impress the concept of bone healing organ, understand why some fracture heal faster than others and some not at all. Importance of soft tissue handling, advantages of indirect reduction and minimal access technique. Use large diameter intramedullary nail where possible. Do not use an all-locked LCB in simple fracture pattern without a tension or compression device. In summary, mechanical stability is important for bone healing. A plate over nail option is a good choice for femur non-union, bone graft for atrophic avascular non-union only, not for hypertrophic. And believe me, stability relieves pain and enhances union. Thank you very much.
Dr. Luai?
Dr. Luai?
Yeah. Dr. Haidar.
Yeah, thank you very much, Dr. Haidar. I think this is one of the best lecture I have heard during this year. This is why I ask you to present it again and again, because I think every orthopedic surgeon needs to listen to this concise and straightforward lecture about the non-union and the technique of bridging plate and 2% movement. I will leave the panel expert for any question. We have time for one question before we move to the next lecture, please.
I mean, it's one comment. Just to say that in non-union, we need absolutely not to be afraid to remove all sclerotic bone. Cleaning the non-union is very important. And I think actually adding bone marrow stem cells to the graft, it can be also a good option to increase the chance of healing. Some people use also bone growth factors like bone morphogenic protein. I mean, there is still some research on this, but I mean, this anyway, it doesn't cost nothing, I think, to add to the graft. What do you think, Dr. Haidar, about this?
Yeah, Dr. Sam, thank you for this question. I think each non-union needs to be studied differently. It is not all non-union treated in the same way. Some non-union need just extra stability, that's all. Some non-union need good fixation. Some non-union need more time, more space to allow the bone to move. So if you open at the fracture site and you see sclerotic bone and you need to remove sclerotic bone at that time, yes, bone graft is beneficial. But to have bone graft or bone morphogenic protein for each non-union, for me, no. Each non-union different from other non-union. Now you see this femoral nail, no need to do anything. Just give him some stability. Just add a plate on the nail and that's all. This is enough for him. So this is the idea. Each non-union has different cause. If you know the cause, we will give the treatment.
Yeah, I think in the femur, the problem is oftenly that we are fixing laterally. And so we don't have stability in the medial side because there is too much forces compared to the upper limb on the femur. So sometimes, I mean, I had one case where I needed to add also medial plate.
Yeah, this is a good idea. Medial plate will give more stability. This is a good idea in some cases, but
yes,
you don't
in some
need it in all
cases,
cases.
because you know the forces applied on the femur are so strong to be fixed by only lateral. So as you said, I think it's a golden rule: is each non-union is a different case, and you need
exactly.
Thank you very much for this wonderful presentation.
Thank you, Dr. Thank you, Dr. Sama, for your question. If you allow me, Dr. Sama, we have to move to the next speaker and next topic. The next topic will be presented by Dr. Sharif Ban. Dr. Sharif Ban, a very well-known orthopedic surgeon who has a special interest in the hand and wrist for open and arthroscopic surgery, in addition to the treatment of upper limb problems and peripheral nerve injuries. Dr. Sharif Ban will give us some tips and tricks and some hints about the distal radius fracture. Dr. Sharif, you are most welcome, and thank you for your participation and accepting the invitation. Dr. Sharif, the screen for you. Thank you very much.
Thank you very much, Dr. Lai, for the marvelous presentation. And I'd like to start my lecture, but I don't know if you can see it.
No, we have to share us the screen. If you just touch the screen with the arrow or your hand, you will see share screen down, the green one. And then if you press the arrow, you'll see, you can then share.
Yeah, just a second.
Yeah, thank you very much. Thank you, Dr. Haidar, for your nice presentation and for your really good rules about non-union, especially the rule of the 2% and the bridging plate, which has to be at least 1/3 of the length. Distal radius fracture is clear now, and Dr. Sharif Ban on the screen. Thank you very much.
Yeah, thank you everyone for attending today. I know it's late on a Friday night, but I hope I can give you a hint or two about distal radius fractures. So I will jump directly into cases. So this is a 46-year-old female slipped on ice. If we look at this AP and lateral X-ray of the distal radius, 90 to 95% of us will say it's acceptable. And when we say it's acceptable, we usually go back to these criteria: that you have a residual radial inclination less than 5 degrees, more than 5 degrees, a palmar tilt more than neutral, an ulnar variance equal to the opposite side, no articular step off of or less than 2 millimeters, step off and gap, and a stable distal radial ulnar joint. But these criteria that we've been raised on for all our lives to stick to when it comes to distal radius do not apply for a lot of things. So when we look at this kind of fracture, you will notice that there is dorsal comminution on the dorsal cortex. And this cortex is very important to prevent later collapse and dorsal angulation of the fracture. And if we treat a fracture like this conservatively, for sure, it will flip into dorsal angulation and cause problems for the patient. So this is why we prefer to fix these fractures. Although they look acceptable on the X-rays, it's preferable to fix them. And this is one of the simplest way of fixing them, using the Kapandji technique, intrafocal K-wires. This is a mix between intrafocal dorsal wire and an interfragmentary radial wire. Now moving on to another case. So this is also a young male who fell at the office and has a comminuted fracture of the metaphysis of the distal radius with dorsal angulation. And this is unacceptable by all means, because there is dorsal angulation, there is shortening, and there is dorsal translation of the carpus in relation to the radius. And this is when the new era of volar lock plates has come inside. And as you can see here, that you have more than 10 or 20 even design of plates that you are more than welcome to choose from. And they will offer you distal locking screws that will give you around 30 degrees of freedom in all directions, as opposed to the classic locking screws, which will go straight in one direction. And this is important in the distal radius to avoid penetrating the articular surface when inserting the screws. So the classic volar approach would be an approach, either the Henry approach between the flexor carpi radialis and the radial artery, or an extended carpal tunnel approach where you can release the carpal tunnel and then drift radially and expose the radial shaft. And a marvelous approach that I like to use a lot, especially in cases with intra-articular comminution, is the extended FCR approach. And in this approach, as you can see here, you will do the incision directly over the palpable flexor carpi radialis tendon. And this is easily palpable because it is the first tendon you will feel when you palpate the skin starting radially. And you incise the skin, and then you expose the flexor carpi radialis tendon and retract it ulnarwards. Seeing this approach, you don't have to look for the radial artery, you don't have to look for the median nerve. You are very, very safe. And then you incise the bed of the flexor carpi radialis. And this directly puts you on the pronator quadratus. Now you can see the retractor here. It has shifted ulnarly the flexor pollicis longus, the median nerve, and the long flexors of the fingers, which you don't have to look for. You can directly go to the pronator quadratus and release it from the radial and distal attachment, and you have a nice view of the distal radius. And even if you go dorsally with a periosteal elevator and release the brachioradialis tendon, you can even reach the dorsal side of the radius. So this approach is your workhorse approach for plating the distal radius. And it's important to notice that there is a watershed line which you shouldn't cross with the plate. And the more important is the volar critical line, which is a line, as you can see here, that is tangent to the tip, palmar tip of the distal radius. So what's the whole idea behind this line? Now, Sung came up with a classification saying that if the plate is within this line, it is considered safe because it's away from the long flexors of the digits and will not cause tendon injury or tendon rupture on the long run. But it can be touching the line. As you can see in shape B here, it's touching the line, and this is Sung B, and this has a probability of tendon rupture later on, or it can be Sung the line.
We lost the sound with Dr. Sharif. I think some Dr. Sharif. So Dr. Sharif is trying to explain to us the volar cortical line and the relation between this volar cortical line and the irritation of the flexor tendon, which is dangerous in some of the fracture when you fix it. So I think we lost the connection with Dr. Sharif Ban. We'll try to get back to him. And if we, what he was trying to say that with the new locking plates, that new technique by using the locking plate for him is the extended volar Henry approach, and using the watershed as a landmark to use his volar plate to avoid irritation of the plates to the flexor tendon when using flexor tendon. And you can add to that approach releasing the extensor carpi, the brachioradialis and release of the first extensor tendon. Then you are you can explore the radial column, and you can even reach the dorsal aspect of the distal radius. And he said that this is the racing course for his approaches. I want to add a few points here till we get Dr. Sharif back. When you see X-ray of the distal radius fracture, the most important to see the X-ray if this is after reduction or before reduction and sent to you. If this is an X-ray of after reduction and referred to you, I think it's the best to see initial X-ray, because if there is displacement from initial X-ray and there is some comminution, this is unstable fracture. It's indication for fixation. And the distal radius fracture is not a one-man show. Expert surgeon with any fracture distal radius can be fixed is not enough. You need to have the tools to allow you to do this job. I think you need.
I'm back. I'm sorry.
Okay, you are most welcome. Please go ahead. You were talking about the volar cortical line and relation with the irritation of the flexor. Please go ahead. Thank you very much.
Yes. Now we move on to a more challenging case. Now you see this.
Excuse me, doctor. Can you share your screen, please?
I'm not sharing it. Sorry.
Yeah.
Sorry.
Just touch the screen again. Yes. Touch the screen again with the arrow or your hand if it's touch screen. You will see the green arrow down, share screen, and then you share the screen with us.
The problem is I think I am, just a second. I'm facing a problem because whenever I don't get these arrows.
Yeah, get a couple of minutes. I will just have some comment on distal radius fracture. It's not enough the expert surgeon and the fracture, but also, yeah, you are back. Most welcome.
Yeah, I'm back.
Most welcome, Sharif. Yes, please
Sorry.
go ahead. Yeah, you can manage always. Okay.
Yeah, unfortunately, not so good at this. So
no, it's okay.
When you meet a case like this where you have a metaphyseal comminution, but when you look at the distal fragment, it's quite small, and this poses a challenge because with our regular plates, you cannot fix this fracture. The plate will be much slower than the fracture, and so you should always have in your arsenal something like this, something that goes above and beyond, very close to the volar lip of the radius, that will allow you to fix the fracture properly. And you can notice these screws, they aim proximal rather than the other screws which aim distal in the regular plates that we use. So you should always, like Dr. Lai said, it's not a one-man show. You have to be really prepared, and you have to really anticipate your problem. And as you can see, this is a Sung sieve plate. This is a plate you aim to remove 9 months or 1 year after your fixation. Anyway, so we move on to more cases. So this is a 60-year-old female. When you look at the PA lateral, it's a comminuted intra-articular. Doesn't look that bad. But the rule of thumb is whenever you see an intra-articular fracture of the radius, you have to get a CT scan. And the CT scan is always criminal because it will show you more than you want to see. So you see here the articular depression and the step off and the involvement of the dorsal cortex, the dorsal comminution, and the involvement of the sigmoid notch. So once you see all of this trouble, you cannot leave this fracture. You cannot look at it and say, yeah, it looks aligned. I will put it in a cast. She's 60, maybe it's her left hand, which is the case. But once you see the CT scan, because it's intra-articular, you have to order it, then you realize how in deep trouble you are. And for these fractures, if you look at the volar part here, it is so small. And the whole personality of the fracture is dorsal. So if you try to approach from a palmar side, you will not see anything, and you will not be able to get proper alignment and proper fixation of this fracture. And so this is why we still sometimes use dorsal plates. Now, 20, 30 years ago, this was unacceptable because there was so much irritation to the extensor tendons and a lot of complications with rupture of the extensor tendons and so forth. But now the plates have become better. The plates have become smaller. The locking screws fit into the plate. So they don't project on the back of the plate. So you have less tendon irritation and less problems. And we usually put 2 plates in orthogonal planes, one radial and one dorsal. And this allows for less tendon irritation. This was the pie plate on the left side, which was in use around 20 years ago. And they found now it's discontinued because there is a lot of tendon irritation. See by this elevation here, which was made to accommodate the Lister tubercle. And now we use these orthogonal plates, low profile 2.4, locked distally, unlocked usually proximally, and you get good fixation. And our classic approach would be to go between the second, the extensor carpi, radialis longus and brevis, and the third and fourth compartments, which gives you a good exposure of the dorsal side of the distal radius. And with this kind of plate, you can get very good articular alignment and very good fixation of the fracture. Now moving on. So this is an 87-year-old female patient. And she fell in the bathroom and she sustained an intra-articular fracture of the distal radius, which is not so common at this age. Usually you encounter extra-articular fractures. But like I said, rule of thumb, intra-articular fraction, even if she is 95, you get a CT scan. Now, when you get a CT scan, you'll notice that you have a loose articular fragment within the joint, and you can appreciate also the dorsal the dorsal comminution and the dorsal fragments, which are quite large, and you will find the volar fragments are quite small and not amenable for fixation. So, of course, this patient is a good candidate for dorsal plating, like the case I did prior to this. But still, you should try volar plating. Why? Because it's much easier. Dorsal plating has still complications. Now, what I did in this case and what a lot of surgeons would do is do the extended FCR approach, where you are able to expose the fracture site. You use a periosteal elevator to elevate the fracture fragments. I used demineralized bone matrix and impacted it into the fracture site, and then put this nice volar lip plate. And I got, I think, not perfect, but fair reduction of the joint and the fragments and fair alignment of the wrist, which is what this nice 87-year-old lady needs. Now moving on. So this is a couple of nice cases also. This is a 30-year-old female, fell off a bicycle. You can see very faint line here of the fracture, and on the lateral, maybe you cannot even appreciate, maybe a small line here. But like I said, never leave an intra-articular fracture untouched. You always ask for a CT scan. When you get the CT scan, you realize that this is a volar coronal fracture, and it is involving also the sigmoid notch. So this fracture, although it looks very benign on the plain x-rays, and you would easily think that this might be a candidate for conservative treatment, once you look at the CT scan, you realize that, no, I cannot leave this fracture. This is a fracture that needs to be fixed, and hence we fix it and promote early range of motion. Now, another case. Now we consider associated injuries. So this is a nice lady, slipped while hiking on the mountains, came 3 weeks late with this extra-articular fracture of the metaphysis with also an ulnar neck fracture. Now, when you find an associated injury of the ulna with the radius, you have to think of the following. This is a very simple way of looking at it. If the lesion or the fracture does not involve the articular surface and does not involve the stability of the distal radio-ulnar joint, then you can treat the distal radius fracture the way you want, and the ulna would be stable. So in this case, an ulnar neck fracture or a styloid tip fracture, you can treat it conservatively. But when we go and we see a fracture that involves the base of the ulnar styloid, where we know that the TFCC is attached, or I fix the radius and I find an unstable distal radio-ulnar joint, these mean that I have to fix and attack this distal radio-ulnar problem. And of course, if I have an intra-articular fracture, either involving the sigmoid notch or the ulnar head, then this needs fixation. So we go back to this lady. We treated only the distal radius fracture with volar plating. You can see that the ulna automatically came aligned and automatically healed with no need of intervention. While in this other lady who sustained a mild trauma with an extra-articular fracture, that looks aligned on the x-rays. I mean, when you look at this fracture, it looks aligned. There is a neutral tilt. There is some loss of radial inclination and height. But as you can see, there is involvement of the base of the ulnar styloid, denoting distal radio-ulnar instability, and there is dorsal comminution, which we mentioned in case 1. And these will lead to poor results if we leave. So always test for distal radio-ulnar joint instability after you fix the distal radius, and this you can do by holding the wrist in maximum supination and trying to force the ulna back and forth. If it is stable, then it's fine. If it's not stable, you should look for the reason and treat it. Like in this case, we fixed the radius because of the dorsal comminution, tested the stability, found mild instability, so I fixed the ulnar styloid using a headless screw. Now, this case is another case where we have associated injury. So he was a guy trying to fix the lamp in his garage, fell down, sustained a simple, an extra-articular fracture of the distal radius. But look at this minor crack here. Now, one of our colleagues decided to do a closed reduction, did a very good closed reduction for the radius, aligned it, but displaced the ulna. And so you cannot leave this fracture for 2 reasons. Now he has transformed what looked to be an extra-articular fracture on the pre-op x-rays into an intra-articular fracture, as you can see here. And he has displaced the ulna. So you have to do both. You have to fix the distal radius and fix the ulna. And this is how it goes.
We have 1 minute, Dr. Sharif.
Okay, I want to say that 80-year-old female slipped in the bathroom, got a fracture like this, extra-articular metaphyseal undisplaced. You decide to leave her, right? And this is what most people will do. It looks nice today, 10 days doesn't look that bad, but see after 4 weeks. There is loss of height, there is loss of radial inclination, there is ulna plus. So these 80-year-olds, even if they are undisplaced, might be considered for fixation, preferably with plates, to avoid these complications. And my last case, this nice gentleman, 42-year-old, had a high energy trauma, intra-articular fracture, like you can see. And like I said, you have to order a CT scan, you have to fix properly. Now, our fellow, this is what he did. This is unacceptable reduction, unacceptable fixation. So, of course, he ended up with poor result, extension 20 degrees, flexion 20 degrees, severe lack of rotation, and continuous pain. And although he didn't fix the articular fragments properly, but still the patient, this is his CT scan after 4 months, has a very mild step off on the articular surface and some gap dorsally. So although you might feel to go an intra-articular osteotomy, I decided to go for extra-articular osteotomy, correct the alignment and the height, and this was his end result. So always look for associated injuries, understand the different fractures of the distal radius, and know how to use your different modalities of fixation to fix the fracture properly and avoid mistakes and poor results. Thank you, everyone. I'm sorry if I went over.
No problem. Thank you very much for this nice presentation. Also, we have a little bit difficulties. Anyway, the message is very clear, and the distal radius should be treated thoroughly by proper preparation, proper experience, and proper implants. I think due to shortage of time because of the technical problem, I'm very sorry. We have to move to the next speaker and next topic. The next topic will be presented by our close friend, Dr. Amin Al-Helou, who's the head of department and consultant orthopedic surgeon in Sheikh Shakhbout Medical City. I know Dr. Amin since long time. He's a very, very busy surgeon with a lot of experience in trauma in all parts of the body. Today, he will speak to us about the fracture dislocation around the elbow, which is, I know it's a favorite topic, always talking about elbow. Most welcome and good evening, Dr. Amin. Please, the screen for you. Thank you for accepting our invitation. Please share the screen with us. Thank you very much. We can see the screen. Most welcome.
Good evening.
Good evening.
Thank you, Dr. Lai, for your nice presentation and for this to give me the chance to share with you some of these cases which has been done in the last few months. For me, this is the presentation. We get it quickly with the to present some cases and just to go through the fracture dislocation of the elbow and to stress on how we should deal with this kind of injuries. We know this is the common injury which happen in most of the cases with dislocation of elbow. It has some sort of fractures there. So this is our goal. This is all before we are trying to stabilize or restore the alignment and restore the stability of this elbow, which is mandatory. We should analyze this fracture and as instability of the elbow. What are the stabilizers of the elbow to understand when we are analyzing any X-ray and CT scan? Any fracture dislocation, this is to happen around the elbow or in the elbow, it should, CT scan is mandatory and you should get CT scan for any case. And this is to put in your mind that this is the main stabilizers for the elbow. What we have, the primary stabilizer, which is the ulnohumeral joint, will have the lateral ulnar collateral ligament and medial ulnar collateral ligament, and the others is for radiocapitellar joint and the common extensor and the common flexor options. We put in mind as when we are following up these patients, we put in mind that this is what are the accepted functional range of motion of the elbow, which is most of people also has any injury of the elbow will come to the surgeon and say, I want, this is the elbow is not extending fully and is not flexing fully. But you put in mind to explain to the patient that he has the functional range of motion of the elbow, which is between 30 and 130 degrees, which is acceptable. You can use it without any restrictions. And this is the difficulties and challenges is usually is always how to restore such injuries. We can go through some cases which has been done before. I can give you one case. It is 40 years old, fall from height, multiple injury patient. He has fracture, chest injury, pelvis injury, elbow, forearm, wrist, and he had complicated with even a pulmonary embolism. This was his the X-rays from the elbow, and here his forearm, how complex the central distal radius. And how this is the CT scan, the 3D for him, how we can analyze all the fractures here. We can find that this all the ulnohumeral joint has gone, and also the radial head as well. We can see also, and this is the distal radius, how he has distal radius problem as well. This is we can go through next. And this is here, we can go through that. This is how we should restore here, and we restore during surgery. The radial head was this not fixable, should be, and we have changed it to replaced. There was a splitting in the olecranon as seen in the CT scan. It has been repaired, and the coronoid was fractured, has been fixed. And this is for, and there also was the avulsion of the lateral ulnar collateral ligament has been restored and done by using anchors. And again for the shaft of the ulna, and again for the distal ulna and the distal radius as well, it is done. This is here, it was done through, this is the menu as we can see from the previous shows that as shown in this, how it is gone through only proximal one approach, and just trying to pass this blade subcutaneously over the ulna, and lastly to do the distal radius. Patient after that, he was functioning well, and he was started immediately after about a few days. Pain has much improved and start to have mobilization even before the removal of the stitches, and he's satisfied about the pain and the shape of his hand. Here's another case, was just it was 27 years old, was just a physician, just has starting his life as a physician, and he fell down in the work, and he came with this X-ray. This year, when we see analyzing, that was someone say analyzing the X-ray. How to analyze? We see here a small fracture here, it is appearing, but it is, as we say, it is mandatory to have the CT scan always for the case. So this is here what we see. This is the fracture of the capitellum and going until the trochlea. Most of the trochlea also has been fractured. And this, it was the challenging how to reach and how to fix this injury, and through which of the which approach we can do. This has been done. This we'll see here the CT scan how the cuts is. It's all most of the trochlea. It is all at the front, and this has been dealt with all through the lateral approach, and just we used just a headless screws, and has been restored. And laterally we found that as well the lateral collateral ligament was avulsed from its origin, which has been restored by using anchor. This is here the post-operatively, and he was given even immediately started to have range of motion, and we have good range of motion approaching to the functional and even beyond. This here another case here we can see it. This is here a lady. She has this fracture due to a fall, and then also we can see how this complexity of the fracture. The both. This is here the olecranon, the coronoid, the trochlea, and the radial head has fracture as well. This is all these fractures here, and this was much swollen, and then has been that was after a few days. After a few days, we did this surgery. After the swelling has little subsided. With this approach, it was the laterally it was the fracture from the capitellum and reaching trochlea and reaching almost to the medial side, but not to the medial column. It is reached only until the trochlea. So we did only this is splitting interfragmentary screws, and also headless screws through the trochlea to hold it in place as shown here. And the olecranon has splitting as well, which needed to have interfragmentary screws. This is here after a while when she was making follow-up in the OPD, and she has it was a little bit has the pain. It is when she is trying to move the elbow, but encourage here just that is the main just to restore the maximum of the function of the elbow should go, and the early mobilization for such injuries. Here another case, which is a 28 years old male. He has, we can see here, how is it? Also, it has the same thing, the olecranon together with radial head and coronoid as well. This is the that is became like classic things we see at common, and this is here what we went for. This was similar than the previous cases. The radial head has been restored, and just we restore the olecranon. Another case, this is here, this is was also this 50 years female. She was radiographer and fell down during her work. This is her x-ray presented to me after about 10 days of injury. And first, this is as usual, we say this is, we always looking for the CT scan is essential pre-operative for any case, which has been also showing this fracture of the olecranon. This is a proximal ulnar radial head and going in this way. So it was unstable elbow as well. This interfragmentary screws between for the olecranon and the blade, and also the radial head, and they needed also anchors to stabilize the elbow with the ligaments. This it was about 6 weeks post fixation. This is another guy. He was after dislocation and came with this X-ray, and this is his. It was his CT scan. You showed here the fragmentation of the radial head and also for the coronoid, and which is we tried to do much to stabilize it, but it didn't come unless we have replacement for the radial head. But this one, there is another thing I have done for him, because when I tried to stabilize the coronoid, the elbow was not stable, was not possible, because it was like a shell and it was big piece from the coronoid. So the only thing I did, I got the radial head, the piece of the radial head, I cut it and I put it as this to complete, or instead of the coronoid in front, in the coronoid of the ulna, and fix it with these 2 screws. So the patient has fixed his elbow and was follow up. He has good range of motion, and his functional range of motion, it was the 25 and 135 after this surgery by about 6 months. Thank you.
Thank you very much, Dr. Muhammad, for your presentation. I have a couple of questions for you. Yeah. You presented the capitellum fracture, which is extended medially.
Yes.
And you were able to fix this fracture because the collateral ligament is avulsed.
Exactly.
So but in case that the collateral ligament is still intact, yeah. I think it's difficult to reach the medial side of the capitellum. In this case, what is your approach? Do you still go lateral, or you change the approach?
This is for this, because this case is like that. It is the main area of the fracture, and the comminution was on the lateral part of the capitellum. But and also if you try to this with the stability, as we said, should restore the lateral collateral ligament stability, you should stabilize. And this is if you have difficulty for that, I prefer this to go from lateral approach normally as it is. But this is for the only thing, this you need to add 1 screw, or sometimes maybe 2. You can make small, this is from anterior to add extra approach for this is just to pass the screw. It is headless screws, is cannulated screws, so you can go through just small steps. You can see it from inside and outside. This is to protect the neurovascular structures, and you go for that. This is,
for me, if the collateral ligament is still intact and you need to reach the medial aspect,
you should go anterior. You should go anterior.
I will not go anterior. For me, the easiest way I do it, I just detach the collateral ligament and dislocate the shoulder. I will put the subluxate the shoulder.
Yeah, this is exactly it was done by the injury for this case. So
this is what done by the injury.
Yeah,
I will do it
but
myself.
Still, but as you said, you can still it like we do some cases in the elbow.
There is another approach which is
osteotomy. Yes, osteotomy. You can like we do olecranon osteotomy, and you made it again in some cases. This is as well. You remove the lateral collateral, and then you fix it with anchors again. Yeah, I'm with you.
Yeah,
yes.
That's what I find it the easiest way. In this particular situation,
easiest
you find
and
yourself
the safest way.
Safest, yes. You cannot see the medial side unless you. So I mean, it is a message here that in the fracture capitellum, which is extended medially, I think the easiest way to do it, if you open lateral, you are already open lateral and you have struggling to reach, you need to reduce it properly. In this case, I will just detach it by osteotomy, by whatever, the way you want, and keep it away, then subluxate the elbow outside, see the fragment, fix it, put the elbow back, and then fix the lateral collateral ligament and start early range of movement. We still have time for from the expert panel, Dr. Sharif, Dr. Safa, Dr. Ahmed, if you have to add a question, or if there is any question. I didn't see any question from the participants. But here there is a question from Dr. Khalid Al-Sisi. He is asking, what is the approach to fix the coronoid? I didn't understand the question, but I think he's asking you how you fix the coronoid. I think you did not fix the coronoid. You took piece of the head of the radius, you put it instead of the coronoid, and you fix it posteriorly, from posterior to anterior by 2 screws. I think your fixation was from posterior to anterior.
Yeah, this is TASE, as you know. This is it was 2 options to do it. I tried first to do this is the easiest way, to bust 2 screws from this, and I found them very stable. But it was in my mind, this is just to put small plate anterior to buttress this piece as well, was to another 2 screws for that.
Yeah, there is another question.
Stable.
Yeah, there's another question for you, Dr. Amin. It's about complication. So what is the most complication you are facing after treating this huge number of complex elbow fracture? And this is a question from one of the participants, I think Dr. Zahid Shah.
Yeah, this is the most common things which you face in such cases, because of if you don't address all the elements of the instability, it is a problem. You will have unstable elbow, and it will be the most common complication is the osteoarthritis. But if it is the complication or the outcome, it is the stiffness of the elbow, which is always I'm encouraging people, which any patient I do elbow surgery for him, it's the early mobilization, which I encourage them after a few days, just as long as the pain is controlled, to start as much as he can to move the elbow. With this, and the continuous and continuous and intensive physiotherapy is the main issue in the elbow injuries in general. We see also, if sometimes if you don't analyze it well, I saw it many times, the patient can come with the fracture dislocation and have fixed the fracture, what you see, and then I found the patient coming after a few months is complaining of pain in the elbow. He cannot do much movements, and because he's feeling something abnormal in his elbow, and you find the posterolateral instability of the elbow, which is really disabling this patient, especially who are manual worker or dependent on their hands. You will feel much abnormal feeling when she is trying to catch something or making any pressure on the hand during work.
Thank you very much. And I like also your comments in the beginning, what you said about you have to set up the expectation of the patient.
Yeah.
You need to, before any surgery on the elbow, to set up the expectation. So patient has to expect some loss of function on his elbow. And this loss of function, loss of range of movement, most of the time will not affect his function. Thank you very much, Dr. Amin. Thank you for sharing with us your huge experience in elbow surgery. I think it's time now to move to the next session. Our next guest speaker is Dr. Ahmed Maher Ibrahim. He's a consultant orthopedic surgeon, and he's working in Mediclinic Hospital, Abu Dhabi, UAE. Dr. Ahmed, thank you very much for sharing with us your experience, and I'd like your talk. And I think it's really needed to have an idea like this. You'll speak to us after sharing your screen. Yes, the management of fracture-related infection. Thank you very much again, and you are most welcome, Dr. Ahmed, and the screen for you. Go ahead.
Dr. Lai, for this great invitation, and thank you for the all organizing committee for the invitation fee for this great meeting. Today we will talk about the management of fracture-related infection. As we know, infection after fracture, one of the nightmares of all the surgeon, especially after complex fracture or open fracture. In this lecture, we will talk about the definition, diagnosis algorithm, classification of infection, of fracture-related infection, the score system, and surgical concept and techniques. Fracture infection after fracture is very challenging in the treatment because of the delay wound healing and permanent function loss with significant socioeconomic cost. As we know that infection post closed fracture can be happen for 1 to 2%, and it can reach up to 30% after open fracture. There is no until now specific consensus about the definition of fracture-related infection because the complexity of the trauma, kind of the patient, type of the implant. But recently in 2017, they reached to the definition of the fracture-related infection. We can diagnose it depending on one of two major criteria. It is sinus tract communicating with the fracture, or two positive identical organisms from the cultures. Or if we don't have these two major criteria, we can get 3 or 5 minor criteria. First of all, elevated ESR and CRB, we're talking about secondary rise, because for sure after any surgical fixation, we will have high ESR and CRB. But if we find secondary rise after this, this is one of the criteria. Also elevated synovial fluid with YBCs more than 3,000 and positive leukocyte esterase strip test. And we will talk about this later on. Elevated synovial fluid with polymorph more than 80%, single positive culture if we get one, or positive histological tissue analysis, what we call about the frozen section. And if we have all these criteria, we can diagnose the definitive infection of our fracture. The clinical manifestation for sure, we have new onset of pain after the fracture for sure, pain with weight bearing or increase with the time. If we have any episode of fever post-operative, more than 38 with induration and edema, or reduce in the range of motion, and this is one of the most sensitive signs. For sure, if we have a sinus period discharge, abscess, and plus the radiological sign like bone lysis, loosening, and sequestration or periosteal bone formation. In this, we just need to look for the histological, the histopathology of the infection. If we can see in the first row of slides, we have the soft tissue affection in the first week. You can see mild inflammation around the fracture site. After 4 weeks, we can start to see the necrosis around the plate and around the infection. And by the end of the 10th week, we can find the full core formation or capsular formation, or what we call the biofilm around the fracture and about the plate. If we look for the fracture site in the first week, it's almost clear, all the inflammation around the bone, but the fracture is fine. But at the end of the 4th week, at the fracture site, we can see the necrosis, the delayed of union, and by the end of the 10th week, complete non-union and complete necrosis of the fracture site. And this is the base of our classification regarding the time. In the early infection, it's less than 2 weeks. It most probably caused by virulent organisms like staph or gram-negative bacilli. Most probably the fracture is not healed. We have immature biofilm yet, so we can go for eradication of the fracture. When we talk about the 2 to 10th week, we call this delayed infection, most probably caused by a low virulent organism like staph epidermidis. And if we have infection after 10 weeks, most probably this is a chronic infection, and we can expect that we have a mature biofilm around the plate, we have a sinuses fistula, and other symptoms of chronic infection and osteomyelitis. The other anatomical classification, we have by Senori anatomical classification, we have type 1 is intramedullary infection, type 2 is superficial around the plate, and this is can we go for definitive treatment with the debridement of the superficial wound. In type 3 and type 4, we have even sequestrum or part of the bone infection or complete bone fragment. And for sure, for both, we need to surgical debridement and remove the segment and later on manage the bone defect we have. Other classification by the AO is depend on non-drainage and drainage. We consider the non-drainage wound what we call dry or quiescent wound for at least 3 months. We can consider this, we can do the debridement in one stage. And the other one is draining wound or draining abscess. This for sure required 2-stage treatment and at least a period of 20 days before the first and second surgery. Also, the host factor is very important to classify our host, because for sure for healthy patient, we can go for debridement immediately. But if we have a patient with a smoker, we have a lot of comorbidities, that patient for sure will think about 2-stage surgery. The assessment IOC that we will depend for the patient factor like smoking, drug abuse, patient with bariatric surgeries or malnutrition, and factor related to the fracture like infection, stability of the fracture, soft tissue coverage, and deformities. Also, we need to look about the duration of the infection, acute or chronic, the fracture healing status, the presence of osteoporosis or not, and as we talk, the type of organism, it's virulent or non-virulent organism. This is the pathway for the organism, for the infection diagnosis. As we can see here, if we have the confirmatory criteria like fistula or perineal discharge, for sure, this is the full diagnosis of fracture. But if we have only the suggestive criteria, like we talk about the radiological signs, the ESR and CRB, and we didn't get the enough criteria, we need to go for surgical exploration. And from the surgical exploration, we can get more information to get full diagnosis of the infection or not. And that's lead us to scoring system for the infection. This done by the prosthetic joint infection on 2017. And consensus on that score, they put the minor criteria in a score system so we can reach a diagnosis. And they give for the elevated CRB and D-dimer score of 2, and the elevated SR1 and synovial LBC 3, the positive alpha difficin, and we will talk about it. This test done is very specific and done by Zimmer. We have a Zimmer alpha difficin we call synovas. That one have up to 100% specificity for diagnosis of prosthetic joint infection. Also elevated by polymorph and elevated synovial CRP. If we have score more than 6, this is for sure a diagnosis for infection. From 2 to 5 is possible. Less than that is not infection. So if we didn't reach to 6 or above, we need to go for secondary score system, which is intraoperative by positive histological specimen from the tissue inside the surgery, or we have a positive pus found inside the wound, or we get single culture of the organism. And that one, and this is a very useful score system, and it's have a nice mobile application. Anyone can get it from the app stores. We need just to give some information about the operative tissue culture. It must be at least 3 specimens. The best site to take it from the bone plate interval. Single could be a false. Swabs are not preferable at all because it can easily get infected from from organisms on the skin. The gram stain is not specific, and for sure we need to stop the antibiotic 2 weeks at least before any culture. The synovial aspiration, we don't give that a lot of intention. We can get a lot of information from the synovial aspiration, not only for cultural sensitivity as much of us will do, but we can get a lot of information like the polymorph percentage, the number of YBCs, the cultural sensitivity for sure. The leukostrep test is very useful test and a very cheap one. This is one of the tests used for urine used for urine detection of infection in the urine. We can use it for for the synovial fluid, and it has very high specificity and sensitivity. Also, we can combine this with alpha-deficin, and this is the alpha-deficin is secreted by neutrophils. That test can be available on Zimmer. We call this Sure. It just bedside also test. You can put part of the synovium on that sample, and you can get a sign of infection or not. Some of the consensus when they combine the CRP and the alpha-deficin, you can be sure 100% sensitivity and 100% specificity of the infection. Also, synovial CRP, we can get information from that. And finally, the crystal or gene, we can do a PCR for that fluid to detect the organism in the synovial fluid. Also, the interleukin 6, one of the very important diagnosis of infection, it have a peak after 8 to 12 hours after surgery and return to normal after 3 days. So we can depend on it for clearance of infection if we have a doubt, because for sure we have high CRP after any surgery. We just need to be sure it can be false positive in rheumatoid or Barrett disease. But what we have, if we have a negative culture, this is one of the big problems facing us when we do a culture and become negative. How can I get a positive culture? First of all, you need to repeat the culture on blood agar or the blood culture. This increase the number and the number of the organism is better than a regular culture. You can ask the pathologist in your hospital to keep the culture for extended culture up to 2 weeks. Sometimes you can get the organism after 2 weeks. Other method like molecular technique, we do the FISH technique or PCR to detect the organism, or direct histopathology from our frozen section from the wound itself. Other method we called about sonication. Just limited in few facilities. The idea of this technique just use the ultrasound to put the plate or implant after removal from the fracture site in a ringer solution, and by ultrasound will rupture the biofilm and the organism will go to the surface. And after that, you will take that fluid and reculture, and we can see in the picture how the difference between the normal tissue culture and sonication culture. You can see you can get a lot of organism, and it's easy to get a diagnosis if you cannot reach it by normal methods. For the radiology, most of the fracture we can diagnose it by the plain X-ray, but I just will give hint about use CT. We need it only to know the extent of the bony involvement. MRI to differentiate if you need to differentiate between soft tissue and bone infection. For the scintigraphy technique, it's limited to pick the skip lesion. If you need to check if the lesion extended to the upper femur or to the lower femur. We prefer the indium more than the technetium because it's more specific and it have high negative predictive value. Finally, for the treatment, we have 3 goals. First of all, to eradicate the infection, to treat the host problem, like if he's diabetic, if it's a smoker, we need to start the antibiotic. The second goal, to achieve a union for that fracture, either by keep the implant or change the implant, and at the end of the third goal, we need to manage the soft tissue problem and the deformity and the stiffness of the joint. In this diagram, it will give us about between the early and late infection. For sure, if we have an early infection, we don't expect that we have immature biofilm, so we can debride and retain the implant. But if we have a delay infection, we need to think about to retain or to exchange the implant. But for sure, if we have a late infection with a sign of the chronic osteomyelitis, for sure we need to remove the implant and make a 2-stage operation and manage the fracture in 2 stages. We can give an example here. If we have non-united fracture, if the fracture is united, we can remove the implant, do wide debridement with local antibiotic or cement, and keep the antibiotic for 6 to 12 weeks. But if the fracture is not united, and if we have a stable fixation with easy for us to do primary closure, we can keep the metal and debride and keep on antibiotic for 6 weeks. If not, we need to remove the implant and to do and do plastic cover, soft tissue coverage, and keep on antibiotic for 2 to 6 weeks for second stage operation. In chronic cases more than 10 weeks, we have two goals, even to go for eradication or suppression if the patient is immune compromised. For eradication, we can go for one step if we know the organism, if the patient condition is fine, no comorbidities. But if we couldn't reach that, it's better to do two-stage operation. For the two-stage, we can do it in short interval from 2 to 4 weeks with local antibiotic and external fixation. Or we can do it we can make the interval on 8 weeks if we think that the organism is virulent, we have a deep infection, we have deep sinuses, so it's better to keep longer time between the first and second operation. Regarding the bone defect, if we have a small bone defect less than 2 millimeters, we can go for acute shortening and local antibiotic. For bone defect more than 3 centimeters in the upper limb, we prefer to do the free fibrillar graft with fixation. In the lower limb, we need to go for other techniques like muscular technique or bone grafting and fixation. If we have a defect more than 5 centimeters, we will go for Elizarov or bone transplant or intercalary prosthesis. We need to, some of the techniques is very important.
We have shortage of time. Sorry, Dr. Ahmed, you have 1 minute only.
So I just will show us some of the technique we need to know, like the masculine technique is very important to manage.
It's important, yes. Let's talk about it because we have shortage of time. Sorry, Dr. Ahmed.
The intramedullary loaded antibiotic, one of the most important techniques is management of the intramedullary infection. The REA system for debridement and irrigation, we can debride the wound and at the same time get the bone graft to irrigate, to use this bone fragment for to cover the defect. Using of PER and curettage to remove every infection around the fracture site, and must be done by the consultant or the by expert surgeon. The aim of just about the local antibiotic, we need to take about, if you keep the semen for a long time, it can make resistant and could be a source of secondary infection. The Papini technique is very useful in calcaneus fracture. For sure, we need to use our plastic surgeon for coverage of any infection, because if you didn't cover the wound and keep it exposed, that will make a acute failure. Elizarov technique is very useful for the bone defect and for acute shortening or bone transplantation, but the functionality is not so good. Finally, amputation, sometimes it's the only solution to keep the patient away from a lot of surgeries. The take-home message that the fracture-related infection is need multidisciplinary approaches and need a large team to manage with. We need prevention for sure is best strategy for treatment, and all factors must properly evaluated at the time of the presentation. And we recommend the two-stage strategy for deep and chronic infection. And thank you.
Thank you very much, Dr. Ahmed, for your session. And I would just remind you that there's a few questions for you. If you don't mind, you can answer it from question and answer panel. And I will also appreciate your a few points you mentioned about the infection and the classification you said, in addition to the new techniques. We move on now to our very senior consultant in Abu Dhabi, well-known consultant orthopedic surgeon and very close friend and brother, Dr. Safa Ad-Din Abaza, who is a consultant orthopedic surgeon, and he's having wide experience in treating osteoarthritis and other problem in the musculoskeletal system. He has a very high interest in the upper extremity and hand surgery problem. Dr. Safa Ad-Din Abaza, please, the screen for you. And thank you for being patient and with me. We are both of us staying together till the end. Thank you for your patience, and please, the screen for you. Yes, this one, Dr. Safa. Please press it. Thank you very much. And please remember that we have only 10 to 15 minutes before we go for closure, please. Do you hear me, Dr. Safa? Dr. Safa? Dr. Safa, we cannot hear you. Dr. Safa? So I think to summarize what Dr. Ahmed was talking about, infection is very important, and I would like to, yes, we can't hear you now, Dr. Safa. Good evening, Dr. Safa. Masa al-khair. Dr. Safa, how are you? Good.
Fine, thank you.
We can see your screen now, and you are most welcome. And thank you very much for your accepting our invitation to participate in the third Frontiers Orthopedic. And thank you, Dr. Safa, for being patient with me, staying till the end. And thank you for the 713 participants till now waiting with us. Thank you for all to being a part of this event. Dr. Safa, the screen for you. Thank you very much.
Yes. If we can see that knee osteoarthritis, actually there is a current therapy only. It's a painkiller or joint replacement. If you see the old definition, it's all around the cartilage depletion and cartilage formation. And we have only two ways. Did you hear? Are you hearing me?
Yes, Dr. Safa, everything is clear. Everything is clear. Thank you very much. Go ahead.
We have only two ways to diagnose osteoarthritis, either gross anatomy or X-ray. Gross anatomy, as you say before, there was 3 signs, 3 symptoms. And for the X-rays, we all adopt the Kilgram classifications, which was adopted by WHO in 1961. But the X-ray as a X-ray, it has a so much limitation. Knee X-rays have a sensitivity about 25% only of the cartilage loss on the MRI. As many persons with structural change consistent with osteoarthritis are asymptomatic. This is the old. In the past, this obsessions with the pathological and cartilage damage came from the UK literatures over the 1950s. And it ended with 2 things, very important things. The clinician, as you and me, they lost the interest because of boring age-relating degenerative persistence disease, and the upper hand and the upper fundamental research come by the biochemist and cellular biologist. But these people, they don't understand that the joint is a mechanical structures, and all the abnormality in the cytokines are rather the result of attempt repair. So osteoarthritis nowadays moving from biochemistry of the articular cartilage to mechanical biology of the whole joint. So the new concept of what is the new definition of the osteoarthritis, structural and functional failure of synovial joint. And this is like a kidney failure, heart failure with multiple phenotypes. It's not one type. And also it has a factorial many risk factors, local and general, the most important trauma and obesity, and the mixtures and the relative contribution of these factors remain to be clarified. So the problem is a pain. From where it comes the pains? And thanks for MRI, slowly we can see a lot of things. So we start one by one. If we come to the cartilage is clear that the severity of the joint damage in the X-ray bear little relation to the severity of the pain. So the exclusions of the other diagnostic possibility is our X-ray, is not to diagnose as osteoarthritis. So it is simply the process of aging. Is the osteoarthritis is a process of aging? No. We find that osteoarthritis is a distinct pathological process different from the aging cartilage. So articular cartilage is both annular and avascular and is not capable for doing any inflammation, stiffness, or any symptoms or any pain in osteoarthritis. So we come to osteophyte and subchondral bone. In the MRI, we see all this. Osteophytes, if we see osteophyte, this is a big study and it was recently studied, and they found that if you have an osteophytes and subchondral bones cyst and all these figures, if it is alone, it doesn't cause pain. If it is subjected and it is associated with effusion and synovitis and bone marrow lesions, then it has a pain. So simply, there is a big study about 400 others, and we found no association between the presence of osteophyte and knee pain. So we come to the meniscal. Meniscal lesion, this is a big subject, and I want to go very quick. It is very famous. It's meniscal tear, 91% of osteoarthritis group with meniscal tear even without symptoms. So we found no association between meniscal tear and pain. And this is very important and very nice study come by South Denmark University. And what they found a lot of things very important. I'm sorry, I want to go back, but what they found that the problem we found that the symptoms of meniscal tear is not due to the meniscus. It's due to early osteoarthritis. And when we examine meniscal tear, always this is McMurray and all this, they discover it is only due to early osteoarthritis. And one of the authors, but I cannot go back. So one of the authors, he realized and he stated that there is no clinical signs, there is no clinical test can test painful, meniscal tear. And this is a turning point. It comes with British Medical Journal in 2016. They tried to make a de-arthroscopic versus conservative management and discovered that conservative management is better than arthroscopic surgery. And this was taken by a panel. And this panel is 8 panels at very big groups, 8 groups, from orthopedics, from the rheumatologists, from the biochemistries, from everywhere. And they discovered that they found that they starting to and they came to a conclusions and guideline. What is a guideline? We make a strong recommendation against the use of arthroscopic nearly all patients with degenerative knee osteoarthritis based on systemic reviewers. Further research, it's a very strong statement that further research is unlikely to alter this recommendation. They make the recommendation in 2017 and revise it in 2019. So this recommendation applied to patients with or without image evidence of osteoarthritis, even in mechanical symptoms, even in sudden onset. So it is not allowed to do any arthroscopy for meniscal tear. And the group from Netherlands, they found that you get 3-fold increase in the risk for future knee replacement if you stick your endoscopy. Also, doctor in Denmark, they found that you will be disappointed in the outcome of this movement. And if you see American Academy of Orthopedics, they say not only was there is no benefit, but also they degenerate the cartilage. And a lot of surgery, a lot of researches, all of them useless procedures, avoid the surgery, highly questionable practice. I personally think the operation should not be mentioned to the patient as an option. The procedure is next to useless. So to sum up, it is common, and it is the symptoms and the signs are not due to meniscal tear. It is due to the signs of knee osteoarthritis. So what we are believing that this is the symptoms of meniscal tear. It is due to osteoarthritis. Clinical tests. The tests are not accurate. Number 2, we make a strong recommendation against the use of arthroscopy. It is a disaster to use this recommendation applied to patients with or without imaging evidence, mechanical symptoms, or sudden symptoms onset. We found why it is this meniscus caused pain. We found that inflammatory mediators, we call it biomarker, in both meniscal and the insynovial. So number 3 is the ligaments. We find a lot of ligaments, anterior cruciate ligament ruptures. If you have a ligament, anterior cruciate ligament rupture, you will get osteoarthritis, whatever you do, operation or you don't. But Dale and Daniel, they found that if you have they found that incidence of radiological after ACL reconstruction, you found a lot of osteoarthritis. Another Swedish soccer player, they make a big study and they found after 7, 12, 14 years of post-injury observation, there is no difference, no significant difference between people surgically treated and conservative play. So there is a big statement from the American associations. They say that there has no study to date that shows that anterior cruciate ligament reconstruction protects the knee from osteoarthritis. So this is another very important study. It's a new one where they found that they come when you do ACL reconstructions, they take the biomarker, and then after 2 years they detect these patients, because sometimes when you do ACL reconstruction, some people goes to a bad outcome and some people goes to good outcome. How we differentiate? By biomarkers. When we do an operation, if you find a lot of biomarker, you are doomed to failure. And this is a very good study. And now we come to bone marrow lesion. Bone marrow lesion, when you find bone marrow lesion, in the past we are calling it bone marrow edema, but nowadays it's called bone marrow lesion. It's not edema. They found 2 things. They increased 9-fold the possibility for total knee replacement, and they found biomarker in there. And this is one of big study. They found that it has a relation to contusions and trauma. And these lesions always resolve in approximately 2 to 4 months. Then we come to synovitis. Our body, we have only our blood protecting us. If you have any problem in anything in body, they protect us by inflammation. Inflammation is cellular biomarker. And simply our knee is a biomechanical, it's a mechanical, mechanical organs. If you have any insult, it goes to damage. The damage goes to try to repair, and the repair by biomarker, and the biomarker is starting to get pain and functional outcome and failure. Then this, by time, it comes to structural damage. And this structural damage, functional damage, is the new definition of osteoarthritis. So if we come to active synovitis, if we have a big synovitis, you get big pain. If we have less synovitis, less pain. And if you have a big effusions, big pain. If you have a small effusion, less pain. So synovitis as a whole is the mounting evidence suggests synovitis is the resultant of, and its resultant pro-inflammatory mediator are important pathogens for Now you will hear all the days. Now this in the literature, you will know about what we call biomarker. And one trial from Mr. Buer et al., he proposed what we call BioBid system to verify what is the type of biomarker. He make BioBid means this biomarker is burden of disease. This is biomarker for investigation, prognostic, intervention, diagnostic, and there is another last one, which is safety. And there is evidence support the use of biomarker as a therapeutic target to development a disease-modifying osteoarthritis drug. There is no disease to modify. We have only painkillers. To conclusion, synovitis is the cause. Presence of effusion may increase pain, and there is a lot of evidence that it can be. This is a very good study. It done in Nottingham in England for 400 persons, and they tried to see if the synovitis and effusions, how much it is common in the population. And they found, they study it by ultrasound, by power Doppler signals. And they study it and they found it is common. You can find osteoarthritis, you can find synovitis, you can find effusions, but the most important, you don't find power Doppler signal. So if you have a power Doppler signal positive, This means it's painful, but not the synovitis. And if you can see, as a surgeon, there is a lot of change in synovial fluid biomarker after high tibial osteotomy. This means the biomarker is indicators for failure or success of your surgery. And in the future, we are going to alter these biomarkers, and then we get a good outcome from suppose surgery for orthopedics. So now there was Hill et al. He found that if you have biomarker biomechanically alters the knee, then it causes change and puts stress on the ligaments and tendon around the knee. So they discovered there is a lot of problems around the knee, including Baker cyst and iliotibial band. Baker cyst is a common and is non-specific, and it is most common among older individual without symptoms. So we come to iliotibial band.
Sorry, Dr. Safa, we have 2 minutes. I'm very sorry.
2 minutes. I have to go to iliotibial band. I have to go directly because this is very important that if you find osteoarthritis, medial compartment, dropped, you will get iliotibial band. I'll show you. I'll go down. So this is my way. And I am using it for 7 years, approaching any patients coming to me in my clinic. Number one, if he's a wet knee or a dry knee. Wet knee means there is a positive ultrasound Doppler scan with varus medial compartment, synovitis, fusion, thickening, and so on. Varus knee with no negative ultrasound Dopplers, this means it's dry knee. And then it's simple. You just deviate. And with knee, the etiology is intra-articular, go and aspirate and give. Even the hyaluronic acids. Nowadays, they put in hyaluronic acid some anti-inflammatory, like they put some mannitol, sorbitol, and this. Dry knee is the etiology is extra-articular, iliotibial band. If it is equivocal, I start with dry knee, and then this is wet knee, and this is the varus knee. We are questioning what is called painful dry varus osteoarthritis. If you have a patient with dry knee, don't think it is due to the osteoarthritis. It is due to extra-articular iliotibial band. This is my take-home message. The people, most of ours in our clinic, what we do, we usually distracted by clinical gross factors. When we see the patient varus knee and walking with difficulty, and very easy, and the X-ray, there is a lot of normal medial joint, and so it's easy for the doctor to say it's osteoarthritis, but it is not the cause. The cause, now we change from the definition, it changed from part to whole joint. The pathogenesis, it changed from biology to mechanical biology. The etiology of pain starts from the cartilage, osteophyte, and to biomarker and synovial. And if you see here, this is my articles in 2015. The first one, dilemma of knee osteoarthritis iliotibial band, and this is the second one, which is a painful knee osteoarthritis iliotibial band. It was in 2020 in May, and this is a reference. And misdiagnosis often lead to omission, inappropriate treatment, or institution unnecessary treatment. Thank you.
Thank you very
Sorry,
much.
it's very
no, it's very clear, Dr. Safa, straightforward lecture. Thank you very much, and we appreciate your points. I will just summarize what we have done today, and I will start with Dr. Safa as he was staying with us till the end. Dr. Safa was talking about knee pain in osteoarthritis, and there is two knee pain as according to his lecture: pain with dry knee and pain with wet knee. He thinks that the pain with wet knee, that there is a fusion which is confirmed by ultrasound, is due to inflammation, and there is extra-articular pain in the dry pain, which he thinks is related to iliotibial band. And according to Dr. Safa, osteophyte doesn't mean that this is that the pain is from the knee. It might be from the ligaments, and always expect osteoarthritis in in a patient with ACL reconstruction, and that's proved, and mainly that because of the initial trauma happened not only to the ligament, happened also to the cartilage. Thank you, Dr. Safa. Thank you, Dr. Safa, for your lecture.
Appreciate your understanding.
Yeah, and also we were with Dr. Ahmed. He was talking about the Ahmed Maher about the infection in orthopedic, and I like he talked about classification and the modern classification, modern diagnosis, and the way of treating such infection. It's very nice to talk about the frozen section when you are in dilemma, and how to extend your incubation and how you incubate it in as a blood culture, in addition to the new methods of diagnosis. Thank you, Dr. Ahmed, for your presentation. And we have also discussed with Dr. Amin Al-Helu some of the elbow fracture cases and complication. And he has stressed on few points. You have to stabilize the bony structures in addition to the ligament structure to able to move the elbow early. Elbow doesn't like immobilization because he will get stiffness early. You need for every patient with elbow fracture to set up expectation. Patient has to understand he may lose some of his range of movement, but it doesn't mean that he's gonna get loss of function. Thank you, Dr. Amin, for participating. Dr. Sharif Ban talked about the distal radius fracture, and he stressed that every time you have distal radius fracture, you have to analyze the fracture properly. You need to have CT scan, and don't forget to examine the distal radioulnar joints. And he talks about the volar cortical line, which is the line from the volar rib cutting down, and if the plate is crossing that line, that means you are endangering the flexor tendon, and that may cause rupture. And every time you put plate and it's crossing that line, you have to remove the plate later on. Thank you, Dr. Sharif, for your presentation. We also listened to Dr. Haider Al-Asadi with a great lecture about non-union and the principle how to treat non-union. I think it was a very, very knowledgeable lecture talking about a very scientific point of view, which everybody, every orthopedic surgeon should know about it. The principle of bridging plate, the principle of 2% movement at the fracture side, and the adding stability by adding plate to the nail, and the idea that we don't need always to add the expensive bone graft and expensive bone morphogenic protein. Thank you, Dr. Haider. We spoke also to Dr. Zaid Al-Ubaidi for elbow fracture in children. It was very nice lecture, and he stressed at that fracture about the ossification center, which you need always to know about it. If you don't need to memorize it, you just let's look at it. And he talked about the line, you have to draw it. And the radiocapitellum line is very important in treating elbow fracture. If you are in doubt, always you can take X-ray for the other elbow to compare between two elbow and see if there is any of the ossification center not inside, especially the medial epicondyle, where it sometimes interrupts in the dislocation of the elbow in children. Thank you very much, Dr. Zaid, for your participation. We have listened to Dr. Muhammad Albaz about the diagnosis and management of complex club foot, and he's talked about the difficulty of reducing the plantar flexion of the metatarsal joint, and the modification of the treatment in the club foot, and also about his preference of POP cast instead of the rigid cast, where he can mold it and give him more flexibility to modify the Poncelli treatment. Before that, thank you also for Dr. Mustafa Kamal Qutb, where he talked about the intramedullary nailing in pediatric, and he spoke about few practical points about how to use it and how respect soft tissue and hematoma, how you stabilize the fracture so the patients can get the proper treatment and to respect also the myotendinous junction, and how you select the size of the intramedullary nail in the upper and lower extremity using the rule of 40 and 35%. Thank you for Dr. Mustafa, or shukran Dr. Mustafa. Dr. Usama Sha'ar also, he gave an excellent lecture about the proximal femur fracture and how you avoid complication, and you have always give attention to the lateral cortex. When the lateral cortex is damaged, your fixation will be in danger, and you need to stabilize the fracture so you can mobilize the patients only, and how much the proximal femur fracture is becoming a public problem, healthcare burden in all around the world. From that point, the osteoporosis treatment has been also raised to reduce the number of osteoporosis, which can expose more patients to proximal femur fracture. Thank you, Dr. Usama, for your participation. Also, we have listened to Dr. Stefan and Dr. Ali Al-Suwaidi about proximal humerus fracture and treatment in different age stages. And we listened that in early, in the young and adult, strong, active patients, the preferable treatment is the even conservative or osteosynthesis with different type of osteosynthesis. In the middle age group, it's a dilemma. There is no clear cut line how to treat fracture dislocation, especially when it is involving the articular surface. You can go for hemiarthroplasty, and the key point is to restore the rotator cuff position, which is restoring and healing of the trochanter. Dr. Stefan also spoke about elderly patients. It doesn't mean you are elderly, that means you have to neglect your patients. You have to treat each patient differently according to his needs and his comorbidities, and also the age. Thank you for all the speakers. Thank you for our participant and audience. There is more than 700 thanks for all participants today. Thank you for organizing committee. And now, before we close, we need to go to the workshop where we have to listen to the workshop today. What's about piroxicam beta, and it can be presented by Fadi Marcos, who is a product manager for New Country Healthcare. Thank you very much for your support, Fadi, and thank you for your presentation. We are ready for you and the screen for you. Thank you very much.
Thank you so much, Dr. Luai, and it's our pleasure. Thanks to all the speakers for their fruitful presentations. Let me share my screen. So
yes, your screen is clear, Mr. Fadi. Thank you very much.
Perfect. So thanks again, and today I'm going to talk about the piroxicam beta-cyclodextrin, the effective balance. Actually, this is my disclosure. I'm an employee in New Country Healthcare, and which is the distributor of the manufacturer KZ Pharmaceutical in UAE as a product manager. And the story starts in 1987 with the Nobel Prize in Chemistry won by Dr. Cram, Len, and Pedersen, who started the idea of host-guest chemistry. This idea, or this technique, was used by KZ to produce the new entity of beta-cyclodextrin piroxicam. The idea of having a host molecule, inert molecule, to engulf the active part, which is the piroxicam, creating a new entity, which the piroxicam beta-cyclodextrin, giving it improved pharmacokinetics. So the old way, or the old piroxicam, which has large crystals with low solubility and long contact with the GI mucosa, giving slow absorption and low bioavailability, moving on to the dispersible formulation, improving the solubility a little bit but still the contact with the GI mucosa a long time with slow absorption and low bioavailability. But finally, we reach the molecule of pyroxicam beta-cyclodextrin with the high solubility, reduced contact with the GI mucosa, and the rapid absorption, giving a complete bioavailability. This is a short video to show the idea of the host gas chemistry used in formulating the pyroxicam beta-cyclodextrin and the comparison between the absorption of both molecules, the pyroxicam beta-cyclodextrin and the normal pyroxicam. So it shows how fast the pyroxicam beta-cyclodextrin can be easily absorbed through the GI mucosa. This gave the pyroxicam beta-cyclodextrin a faster absorption than the plain pyroxicam, which has been proved in a Acerbi study in 1990, giving a faster onset of action and faster absorption. And this also reflected on the single drug administration with pain relief when it was compared to the plain pyroxicam in Manzini study in 1989. Pyroxicam beta-cyclodextrin also show greater efficacy when compared to diclofenac in Riccieri study in 1990, comparing the osteoarthritis patients single administration with a reduction of the mean value of the pain intensity with a significant percentage than the diclofenac. Again, when comparing on the longer term of 3 months to 6 months, the pyroxicam beta-cyclodextrin compared to diclofenac improved the daily living activities assessed by the health assessment questionnaire in the Montagna study in 1998. On the other hand, on the safety profile of pyroxicam beta-cyclodextrin when compared to the normal pyroxicam on the level of the gastric damage score, the patient which was worsening due to gastric damage was the percentage of them was significantly less when using pyroxicam beta-cyclodextrin compared to the pyroxicam in Muller study in 1997. On the cardiovascular risk, and this was a meta-analysis of a 10 years systematic review published in 2011, it compared the non-steroidal, whatever they are, COX-2 selective non-steroidal or non-selective non-steroidals. It shows that the pyroxicam similarly appear to the naproxen in the risk of cardiovascular events. So, which is the naproxen, again, it's considered one of the safest or the lowest risk cardiovascular non-steroidal. So to wrap up, the pyroxicam beta-cyclodextrin, it's a powerful analgesic activity, faster onset of action compared to the normal pyroxicam, improved GI tolerability, and a minimal cardiovascular risk. So by this, I would end up my presentation, and thank you so much for inviting me, Dr. Lai, and thanks to all the speakers and the organizing committee.
Dr. Loy, can you unmute? Dr. Loy?
Wala na siya ay...
Tell him he's not on. He can hear me.
Dr.
Loy? Hello, Dr. Loy? Yeah, he can speak. Dr. Loy, you can resume now.
Hello?
We can hear you, doctor. You can proceed. No, doctor, you can speak. Hello, Dr. Luwai. Hello, Dr. Luwai. Hello, Dr. Luwai. Hello, Dr. Luwai. No.
Can you hear me now? Yeah, okay. So if you can hear me now, that's good. At the last moment, you cannot hear me. So thanks for the last presentation done by Fadi for his Porexicam, which was straightforward. And thank you for all the speakers. Thank you for all the participants, the organizing committee and the scientific committee. And hopefully that you have enjoyed the meeting today, and we hope that we will see you again in the coming fourth Frontiers Orthopedic Conference, which will be inshallah soon, and maybe it will be presented live in addition to online. Thanks for all the speakers and audience, and hope for you a very nice evening, and see you again next meeting. Thank you very much.
Thank you, doctor.